Recording now? Yeah. Yes. Okay, there we go.
Good morning. Good morning to everybody in the room, and good morning to everybody that's decided to sleep late and looking at the recording a little bit later. We're very happy to have everybody in the room today, and I just want to start off by thanking Tanya for all of her hard work, putting a program together like she did. It's not easy to put a program together specifically on a Saturday. And then also to Dr. Ziki, Francis, and Mia, that's our experts coming in today to speak to us. Thank you so much for your time today. World AIDS Day is a very special day for our disease. It's an annual awareness day that's dedicated for people with axSpA, and it basically happens the first Saturday of May. And we've actually got 60 patient organizations in 45 countries that's celebrating this with us. And the aim of World AIDS Day, of course, is to raise awareness, to share information, and to connect with each other like we're doing today. I think what you guys have seen clearly in all the World AIDS Day videos of this year is we focused this year's theme was it's not only back pain. And in all the videos you saw on our social media with all the patients shared all the different comorbidities that they have, such as fatigue, IBD, mental health. And that is also why we've got these speakers today that's going to shed some light for us on these topics, because these are seldom the matters that's not discussed in detail. And because axSpA is missed a lot of the times, and people wait a very long time for diagnosis, understanding the full picture of the disease is very helpful for us to early diagnose patients. And of course, conversations about these topics can lead to earlier referral and can create awareness. So we are very responsible to also create awareness of the disease by talking about it. Lastly, I would like to invite you to sit back, enjoy the talk. Don't forget to keep on moving, and happy World AIDS Day, and we're very happy to be in the room with all of you today. Dr. Ziki, Tanya, are you there?
Yes, I'm here. I'm here. Yeah, I did send out some speaker information, but if anybody didn't see it, I don't think Dr. Ziki needs much introduction. She's been such a pillar that we can lean on with our World AS Days. She's a very experienced rheumatologist. She specializes in autoimmune and inflammatory conditions, including axSpA. She's the founder of Room Care Clinic, and she really has a wealth of knowledge, and she's not afraid to share with us. She's passionate about improving access to quality rheumatology care across South Africa and beyond. And yeah, Dr. Ziki, thank you so much for joining us today. I think we are all very interested to learn more about fatigue. And without further ado, over to you.
Thank you, Tanya. Thanks, ladies, for the invite, especially to Elaine for helping me, for guiding me with this talk and what she thought would be pertinent. Yes, I mean, I do agree. I mean, fatigue is a very important and common symptom that is underappreciated among our patients. And it's a good thing that the Axial SPA support group has decided to include this in this year's talks. So I'm going to give this talk in light of my clinical experience what I've experienced with my patients. So that will be the basis of this talk. Okay. So the background, like I said, is based on my clinical experience in the room care clinic. And what I've observed over the last 6-7 years of my experience is most of my new patients complain of fatigue. I haven't done an official study, but almost over 90% of the patients have fatigue across the conditions. And most of the patients with active disease do report being fatigued. And some of the patients with low disease activity or who are in remission do have fatigue as an ongoing symptom. And it is associated with lupus, rheumatoid arthritis, and spondyloarthropathies. And the other common symptom I get from my patients is poor sleep, fatigue, and a desire to lose weight. And it seems these three are also not appreciated or talked about, but very important among the patient. And it's an important concern in over 90% of my patients. And fatigue does form part of the classification and disease activity scores for lupus, spondyloarthritis, and Sjogren's. And these are the common statements I get from patients that I have brain fog, I can't concentrate at work, I can't sleep. Despite being active, I'm still tired. And most patients are tearful when they relate to these symptoms. Or they'll tell me that this is not me, I'm capable of doing more. My life is not the same. Even if I exercise, I'm still tired and I take long to recover. And I can't take the pain. I can take the pain, but I can't take the fatigue anymore. And the causes of fatigue in room care clinic among our patients, the commonest are related to active disease. And usually when we manage the conditions, the fatigue improves in some of the patients. Drug-related side effects, poor sleep, lack of exercise, other chronic conditions such as cancers, organ failure, nutritional deficiencies, menopause, psychosocial factors, chronic stress, depression, and central desensitization seen in most of fibromyalgia patients. And looking at each of these causes, that's the next few slides. I'm going to try and explore each cause into a little detail. In terms of rheumatological conditions, we found that there is a significant improvement of fatigue symptoms with optimal treatment, and this usually includes the use of biologic DMARDs and TNF alpha, which includes our adalimumab, Enbrel, usually does help with the reducing fatigue. And these cytokines have been implicated in the pathophysiology of fatigue. And currently interleukin-17, which is pivotal in spondyloarthropathies, is being studied to be part of the fatigue cause in terms of cytokines. And then in terms of drug side effects, methotrexate, Rumalif are usually the most drugs that I hear patients complaining about in relation to fatigue. And the one is the post-methotrexate fatigue. So it's a once a week medication, as you all know, and most patients do complain of fatigue a day after or two of taking methotrexate. And the usual advice is try and split the dose into two. Instead of taking it on one day of the week, you can take it into two, so that decreases the dose burden and decreases the fatigue. Or consider avoiding, which is usually the general recommendation, not to take folic acid on the same day that methotrexate is taken. That also helps reduce the fatigue. And also among our patients, there's a use of multiple painkillers, anti-inflammatories, and some of these are related with fatigue as a side effect. And due to multiple comorbid conditions, there may be drug interactions that also exacerbate fatigue. Steroids, one of our pillar drugs, does impair sleep, especially it affects the circadian rhythm. And then patients can't sleep well, they are poorly rested, and they are tired the next day. Or antipsychotics, as most of our patients have mental health challenges and are taking these drugs. And if you look at the mechanisms of how antipsychotics cause fatigue, I mean, there are over 10 mechanisms, and over 50% of our patients are on this treatment. Lack of sleep. So sleep is a very important factor, which I think next year it should be included in the talk, how to improve sleep and the impact of sleep on autoimmune or spondyloarthropathies. And sleep is a significant contributor in the pain, fatigue, sleep cycle. And if one does not sleep well, it affects many areas of life, decreases function, decreases mood, and also affects fatigue. And the various reasons I hear from my patients why they can't sleep is stress, pain, and exposure to blue light. Everybody's on their cell phones, especially with the social media. Patients tend to exercise late in the day after work, and this also affects sleep. Intake of coffee, medications that affect the circadian rhythm, like the antipsychotics I mentioned. Glucocorticoids also affect the circadian rhythm. Poor sleep hygiene, psychosocial issues, mental health related issues. All these factors do contribute to poor sleep, and improving sleep has been shown to break the sleep pain fatigue cycle. Lack of exercise. So due to various constraints, most of the patients are not exercising or do not have time to do that, or pain itself is limiting exercise or depression. And in terms of exercise, correcting the timing of exercise is crucial. So some literature even suggests one should not exercise after 5 or 6 p.m., as this can affect their sleep. And exercise regimens that have been shown to improve sleep is aerobic exercises, resistance training, as these improve mitochondrial function and reduce fatigue. Stretching, yoga have also been shown to improve pain in spondyloarthropathies as it improves enthesitis, which is one of the hallmarks of the spondyloarthropathies. And then we also look at other chronic conditions. So if one has fatigue, it's not a one size fits all. So one has to look at all these factors. And one important factor is chronic conditions. So our patients are at different phases of life. So it's always important during consultations with your rheumatologist to explore these issues or to discuss other areas of one's health. And the commonest causes are endocrine issues, hypothyroidism. And if it's not well controlled, one can be tired from that, or other hormonal problems, cancers. So in my clinic, as part of routine care, I encourage all my patients to have frequent GNC scopes, mammograms, pap smears, PSA testing as part of cancer screening, mental health related issues. So it's always good to explore one's mood and psychosocial status during consultations. Infections, organ failure, especially kidney and liver. And part of our routine 6-monthly bloods, they do include kidney and liver screening. And patients with comorbid conditions, my advice would be have a GP that you visit at least once or twice a year so that they can look at your health holistically, or a physician if you've got multiple comorbid conditions, or even your rheumatologist. The issue with most rheumatologists, we tend to concentrate on our primary conditions. Hence, other issues may be missed. So it is vital for patients with comorbid conditions to have a dedicated sessions with their GP or physician to discuss their comorbid conditions. Nutritional deficiencies, so B12, vitamin D. Surprisingly, vitamin D deficiency is becoming so common, most likely because most of us are not exposed to sunlight. We are in the office, we are in malls, we are driving, we use sunscreens, so our vitamin D levels are very low. So for all my patients, I screen for vitamin D at baseline. And if fatigue becomes a problem along their care, I do include these tests. And iron deficiency is also a common cause. And if one has iron deficiency, I also screen, and this usually includes a G and C score, because cancers of the gut are common and they can present with iron deficiency anemia. Magnesium is another nutrient that may be deficient, and you find most patients are now taking magnesium glycinate to help with sleep, and this could be some of them have deficiencies in magnesium. Menopause, I've been caught out many times with regards to females going through this phase of life. And sometimes one thinks, oh, my patient is too young to be going through menopause. But you find that literature does state that menopause, perimenopause can begin 15 or more years before the actual menopause. So if you look at menopause onset happening at the age of 52 to 55, so it means patients in their 30s, mid 30s, could be beginning to experience symptoms of menopause or perimenopause. And these symptoms include non-specific symptoms such as insomnia, fatigue, mood changes, and this should always be discussed with patients. And you find that I also tend to encourage my patients to have frequent discussions with their gynecologist or general practitioners so that this can also be explored. Relevant hormonal tests can be done, and if needed, hormonal replacement therapy can be given if it is safe for the patients. Other supplements that I also tend to add if I suspect perimenopause are evening primrose oil, and some patients actually volunteer to go on to natural hormonal supplements. And this tends to alleviate some of the fatigue related to menopause. And exercise, a balanced diet, hydration has been shown to improve the symptoms of menopause, or perimenopause rather, which is what our patients will commonly present with. Chronic stress is also another big one. All of us are going through difficult times in different facets of our lives. And I find that most of my patients who flare from a low disease activity or remission and present with flares, or the presenting complaints are usually related to traumatic life events. And this can include divorce, accidents, death, work-related, family-related challenges. And you find once one is experiencing these stressful events, this has a physiological impact that results in release of neuroendocrine hormones linked to cortisol dysregulation, affecting your sleep, increasing inflammation cytokines, our interleukin 6, our TNF, resulting in fatigue. And as I was doing this, preparing for this talk, I was surprised to realize there are over 15 mechanisms on how chronic stress can impact the fatigue, sleep, mental health issues. So again, this is a topic that can be explored in the future, in future annual days for axial spondyloarthritis. And fatigue in some of our rheumatological conditions present differently. So in rheumatoid arthritis patients, it tends to correlate with early disease when patients are not yet on treatment. And as one gets into remission, the fatigue improves. And we then tend to see fatigue flaring if there are other background psychosocial factors or any of the other issues that I mentioned in the previous slides. In lupus patients, fatigue is often disproportionate to disease activity. So you find that a patient is well controlled, but they do complain of fatigue. And fatigue is one of the markers of disease activity in lupus. Fibromyalgia, fatigue is a big thing in fibromyalgia, especially when associated with chronic pain, with emotional instability. I tend to then suspect fibromyalgia. In spondyloarthropathies, it is linked to pain and sleep disturbance, mostly because patients have stiffness in their spine, the enthesitis, which is causing pain and hence affecting their sleep. And in spondyloarthritis, fatigue is poor but really under-recognized symptom. I mean, when I started seeing patients in private practice, I was surprised at the number of patients who complained of fatigue. And in my early days, I thought the patients were pretending because I couldn't understand why everybody was so tired. Every other patient was tired. But as I matured in my practice, I realized it actually is an important symptom with the spondyloarthropathies. So now I tend to ask if patients don't volunteer this symptom, I tend to ask about fatigue. And fatigue does contribute significantly to work disability, impaired quality of life, and reduced function. I mean, you find that sometimes as a clinical and as a clinician, you don't realize that you are seeing a patient presenting with a clinical problem, but they are a mother, a father, a sister, and you find husbands coming in and they you know they're emotional about the fact that they can't play with their children. They want to run around with their children, but they can't. They come with their wives who are disappointed in their partners because they are not available to do other social interactions with them because they are always tired. And so this can actually end up impacting one's psychosocial life, one's marriage, one's relationship with their children. So it's a multifaceted problem in our patients' lives. And you find that in spondyloarthropathies, sleep is fragmented due to the pain, and hence one wakes up feeling tired. And of note, fatigue is part of the BASDAI score that we use to assess disease activity. And this cycle, the pain, sleep, fatigue, pain, sleep cycle, I think it's something that I also did not appreciate until I was preparing for this talk. Because you tend to look at this problem in isolation. You find a patient complaining of pain, complaining of sleep and fatigue. And as a clinician, you want to address it separately, but it's actually a cycle. It's one thing, it's linked. One thing leads to the other. One is in pain, they can't sleep, they wake up feeling tired, they are tired, it increases their pain sensitivity, and it leads back to poor sleep. So as a clinician, I mean, one thing I've learned from this preparation is I need to look at this problem as a cycle, as a one unit, and try and discuss it holistically with my patients. And within this cycle, there are multiple processes that are happening. And one of them is it increases pro-inflammatory cytokines, our interleukin-6, our TNF. It dysregulates the neuroendocrine pathway, and hence it becomes a vicious cycle. And sometimes it's independent of inflammatory activity. And that is why you find patients there's no joint pains, there's no joint swelling, the CRP is normal, but patients are just tired. And it's because this is sometimes not linked to inflammation. And within this cycle, sleep has been shown to be the one modifiable driver that one can work on and improve the outcome, or break this cycle rather, and improve the quality of patients' life. And exercise is also important, though sometimes it's very difficult for patients to initiate exercise because they are tired or they've got low mood. And when approaching this cycle, one has to look at it, like I said, in holistically, and that knowing that it's a multi-modal intervention is required. And it's not a one thing leads to the other, but there are many factors that are involved in this cycle. And also the EULA and ACR guidelines, which we do follow as rheumatologists worldwide, it does acknowledge that sleep disturbance is recognized as one modifiable driver of fatigue in inflammatory conditions. And the management of sleep is supposed to include pain, mood assessment, physical activity assessment, and disability, and with non-pharmacological strategies central to care. So my advice to patients living with the rheumatic conditions is when you visit your rheumatologist, at least have some notes in preparation for the consultations, so that sometimes you find if disease activity is not the focus of your problem in that consultation, then bring these issues to your rheumatologist so you can have a dedicated discussion. And yeah, I actually encourage my patients that every consultation, let's have a theme of what you want us to discuss. And you find that fatigue, sleep, weight are always issues that are close to patients' hearts more than their disease activity in some instances. And these are some of the tools that we use to assess fatigue in rheumatology. And these are some of the emerging concepts with regards to pain, sleep, and fatigue. And research is now moving towards these areas. The microbiome, the gut-brain axis is one big area, and it's something that we all can do. We can increase our use of probiotics, or even things like yogurt, kimchi in our diet to improve that gut-brain axis. The role of interleukin-6 blockades in fatigue modulation is also under investigation. The use of digital wearables like our watches. I mean, you find the Apple Watch does assess sleep quality. It does give us our exercise intensity, timing. So all these are prompts that can digitally help us improve sleep and fatigue. Interleukin 17 is also being investigated with regards to its role in fatigue and how it can be modulated. And like I said before, with spondyloarthropathies, enthesitis has been shown to be the biggest pain contributor and sleep disruptor in this patient. And also this slide is a summary of what I've learned from my patients in terms of what they are trying out to improve their fatigue. I don't have much knowledge in some of them, but I've just listed them here as something that can prompt the initiation of discussions around the use of these non-traditional interventions. And most of them are not SAPRA registered, but patients are using these strategies. My approach or advice to my patients is if you can afford them and if they don't cause you negative impact, try them out. And when you come for follow-up and if I pick up any abnormalities in the blood, I will advise you to stop the medications. So there are various peptides on the market and patients are using these molecules to improve various areas of their health, which include fatigue and sleep. Creatine is being used for muscle strengthening. But my observation with this molecule is patients are coming in renal failure with creatine. I've had to advise 3 or 4 patients since the beginning of this year to stop using this supplement or to reduce the use because of kidney issues. Women are using testosterone around menopause and perimenopause to improve fatigue and strength. I also don't have much knowledge on this, but I have patients who are using it. Natural supplements such as ashwagandha, devil's claw, ginseng, these are also commonly being used by our patients. And even things like cold pool plunges, they are also being used. How much they help, I'm not sure, but I'm sure they have value as add-on to traditional medications and interventions. My practical advice, aim to optimize disease activity, as this can also significantly contribute to fatigue. And so have an open discussion with your rheumatologist, understand how your disease activity is being assessed, where you are in terms of disease activity and your treatment pathway with your rheumatologist. I know sometimes we are busy, but I think patients are now empowered. There's lots of sources of knowledge. Take charge of your health and initiate these discussions. Sleep improvement, sleep hygiene is vital. Consider medication to assist in sleep. So things like melatonin, magnesium glycinate, exercise, multidirectional thought processes with your physician in discussing fatigue, escalation of DMARDs if needed, although escalation of DMARDs is not always equal to resolution of fatigue because your fatigue may not be linked to disease activity, but to the other factors I've mentioned before. Cognitive behavioral therapy is also crucial, and yes, a broader discussion with your rheumatologist. So in summary, or my take-home message is a holistic life that takes into consideration sleep. And I think sleep is the most important part of our life that will improve many facets of our health, especially fatigue, which is the discussion of this presentation. A healthy diet. We tend to encourage Mediterranean diet, high plant-based diets. Exercise, aerobic exercises, yoga, stretching, even walking if the body allows. And I find most of my elderly patients are doing water aerobics with very, good outcomes. Compliance on one's treatment is important. Journaling has also been shown to reduce stress. Improving social interactions has also been associated with longevity. So it's something that we should all pursue to do. And moments of doing nothing, just doing nothing, has been shown to improve fatigue because one gets to rest, one gets to de-stress, one can exercise during that time, and you find that the sleep quality may also improve. This is the end of my presentation. I don't know if there are any questions.
There's one question here in the chat, Dr. Ziki. Is CFS and ME and long COVID also worth being investigated along with axpar fatigue? And which specialists would you see for these conditions?
Which is the long COVID? That's basically what they're asking.
Yeah, I mean, can you even differentiate between which one is responsible for the fatigue, or could it all just be contributory?
I think it's all contributory. And I mean, like I said, after reading through this topic in preparation, my own learning point, as a clinician is don't look at fatigue in isolation. Look at all these factors, irrespective of what the patient thinks, whether it's infections, they could still have vitamin D deficiency. Their disease might still be not well controlled. They may not be sleeping well. They may not be exercising. So I would still look at whatever type of fatigue it is or the source, be holistic in the approach.
Dane, does that answer your question? Good. Any other questions for Dr. Ziki?
Yes, Tanya, I also have another question.
Mm.
Um, uh, Dr. Ziki, firstly, it's good to see you again. I've missed you. I've moved down to Cape
Right.
Town, so I haven't been seeing Dr. Ziki since I moved down. I hope you're well. When I was with my psychiatrist, she actually prescribed me a concentration medication called mifedanil. I first tried another one. I can't remember what it was called. It was some other medication. And that particular concentration medication has rapidly increased my ability to work longer hours and have less fatigue. I'm still fatigued. I'm still like all the things you described in the talk. I still struggle to work 8 hours a day, but the ability to now work between 6 and 7 is much better, and I'm able to exercise more and achieve other things more than when I first came to you when I was only working 4 or 5 hours a day. So is that something that is also being looked at, or does it have to be prescribed by a psychiatrist or a neurologist, the concentration medication?
Well, I haven't script. Nice to see you, and when you're looking good. I haven't scripted the medication. I'm not aware of it. So I think there's a lot of work and non-traditional, non-formal or medications that we haven't been aware of while during our training that is now being used. And so I think it's an evolving area. And if something works and I would use it because there's no one answer for this problem. And you may find if you like from my talk, it's not just rheumatologists who are going to be faced with these complaints. Psychiatrists are going to be faced with the same complaints, and they will probably explore a solution in relation to psychological or psychiatric related conditions and come up with solutions in that area. We may be coming up with answers such as split your methotrexate dose, avoid taking it on the same day. Let's optimize your treatment. Let's give you a biologic DMAT. And that is our solution to the fatigue when you look at it from our area. So I'm not aware, but I think everybody is trying to come up with answers. Endocrinologists will be doing the same from their side. Sports physicians will be doing the same.
Okay,
So
thank
maybe
you.
we need to sit in one room and have this chat with all different healthcare providers.
That would be lovely indeed, to have sort of a whole panel of everyone that has anything to do with AXPAR or the psychological effect. I always said if I win the lotto, I want to do like a rheumatology center where we can have all of these specialists together working as a team. But that's just my dream. Um, and Dr. Ziki, we've got a question here from Aisha. Is it possible to live or get back to living a normal life with AS? The fatigue and pain is overwhelming and I'm unable to work. I'm in my mid-30s, so still very young.
Yeah, I always encourage my patients to be positive, especially a 30-year-old patient. I mean, you still have a long way to go. So it's good to be positive as a starting point. And whether one will be able to work or not, I mean, I really can't say. Uh, and like I presented, I would really look at all those areas in one's life. And not in relation to Aisha particularly, but you find when you now have this holistic discussion with patients, you pick up things like, oh, I actually exercise at 7 p.m. I go to the gym late. I have a coffee before bed. And for example, I had one patient I struggled with, I was co-managing with a pulmonologist for a whole year, and she couldn't sleep. And we did all we thought we can for her. Only once we stopped her prednisone, and then she said, I can now sleep. So we all missed the fact that we were giving her prednisone and she couldn't sleep. So I think a holistic approach to fatigue is important. Find what you can change, what you can work on, what you can improve on. And once you have explored all those options and you still are fatigued and can't work, then yes, one may have to consider working less hours, uh, part-time, mornings only, if financially possible. But yeah, I think most of my patients, I think 80%, when we sit down and discuss holistically, we identify something that can be changed, and that usually has a significant impact on one's life.
That's great. Thanks, Dr. Ziki. Aisha, I think the message here is that we need to see our rheumatologists. We need to discuss everything with them. I think Dr. Ziki's idea of actually putting notes together before you see your doctor is amazing because often I know with me, we all have brain fog. So the notes would be perfect because often after your appointment, you sit and you think, oh, I forgot to mention this, or I should have asked that. So I think it's very important for us to communicate with our doctors. And if our treatment regime is not working, we need to tell them. If we say, the fatigue and the pain is so overwhelming, it's not, whatever I'm on is not working. Speak to your doctor. Let them help you. Let them investigate alternative options. Do you have any other question, Aisha, or are you? Anybody else with a question for Dr. Ziki? Come, guys, we've got her here. Like, she's at our disposal. Ask now or forever hold your peace.
And maybe while we are waiting for the next question, I mean, I also notice it quite a lot, Patients then feel after a consultation they've not been served well, but I can't guess what your issues are, because there's a lot to talk about. So it's very important that patients empower themselves. They take charge of their health. I'm there to guide you. I'm there to help, but I'm not responsible for you. I mean, it's your health. And I think we need to start educating each other that we're working as a team and each one has a role that they play in the healthcare journey. And I think patients will get better help and outcomes of their health.
Yeah, I think that's a very valid point. And like you say, you can't guess. And everybody's symptoms is different. We don't all experience the same, even though we have the same disease. There's so many different things that you can experience. Some have enthesitis, some don't. Some have really bad back pain only. Others, it's more somewhere else. Some days it's different. Today it might be a foot, tomorrow it might be a hand. We don't know. So communication, I think, is key. Anyone else with a question for Dr. Ziki?
Sorry, Tanya, I have one more question. What I've experienced with Dr. Ziki, and maybe you can also speak into this with other patients, doctor, is that when I had my main complaint was fatigue because the pain resolved pretty much soon after I started seeing you in 2022. I think 2022 to 2023 there was pain, and then from 2024 to 2026 it's been fatigue is my main complaint. Is that I was able to speak to my psychiatrist and speak to you about the fatigue and kind of email you both and ask you both about the same thing around my fatigue and how, like what you spoke about earlier about getting together with other healthcare professionals or just collaborating with them. How willing would you say rheumatologists are in general? Because my experience of you and other rheumatologists that I've met, I was at the SARA conference last 2 weeks ago, is that they seem very open-minded and not very egotistical medical professionals. They were very, very willing to work with psychiatrists, neurologists, pulmonologists, as you've just shared. Is that something that is worth doing with people? Also, a lot of people have multiple autoimmune conditions that have got links to different systems. Is that the future of managing autoimmune conditions is collaboration with different specialists working together with a patient so that there's more teamwork? Is that something that would be a fair way to kind of approach the fatigue issue?
I think it is, like Tanya said, it's also my dream one day to have a center where we have different specialists looking after a patient, because rheumatology is multi-systemic. We don't deal with one organ. So, for example, a lupus patient can have brain issues, can have heart issues, can have lung issues, skin issues, eye issues, and then joints. And to have this patient running around from one specialist to the other, it's a disservice. And I think it fragments the care. But if one has a center of excellence or rheumatology care center with all these specialists, it would help. And looking at our current digital era, it probably we might not have to be all physically in one place, but probably create a virtual clinic where one can, I don't consult with these specialists on one platform. Maybe that is what we need to be thinking about. And like what you are saying, it's also a virtual collaboration that you do for yourself, so you're taking responsibility for your health, you're taking initiatives for yourself, you're reaching out to different specialists on your own, and you're not coming to my rooms, you're not going to the psychiatrist's rooms, you are using the digital platform to say, okay, I've got these people's emails, let me email them. And I'm seeing that more and more, that patients are sending out emails to 3, 4 specialists in one thread asking about their problem. And I think that's the way into the future, that healthcare is becoming more and more patient-centered. In the past, patients put all their trust in their healthcare providers. Patients would come to us and expect us to be mini gods, but now I'm seeing a shift in the way people are consuming health. They're taking responsibilities. They come in and they tell you, look here, this is what I've been monitoring with my phone, and this is what I'm picking up. What do you think about this? So we are moving away from being little demigods into being healthcare partners with our patients, because our partners are informed. I mean, information is everywhere. So patients are informed, and I think the future, the way I see it now from my physical center that I used to dream about, I'm looking more at a virtual clinic, where we can collaborate as specialists and offer this holistic care to our patients. And it will be at low cost because there's no rental, there's no transport, but we are still offering that care. And sometimes it's not about touching patients, it's about discussing like we are doing. This is care. We're discussing a concern, but it's all virtual, and it's one specialist talking to 15 patients. You all don't have to pay single consultation fees, but it's combined on a digital platform. So I think that's where the world is moving to, a digital platform, virtual clinic, holistic care, patient-centered care, patient-initiated treatment pathways, and doctors or rheumatologists acting as treatment buddies. So I call myself a treatment buddy for my patients because they have more information sometimes more than me. Like the one slide I showed you, I've learned a lot. Like peptides, I learned that from patients. Ashwagandha, I hear that from patients. Cold pool plunges, I hear that from patients. So I'm also learning, and then I go and read about it, and I can share it with you guys on this platform. But not that I initiated my own learning, it was patient initiated. So I think that's where I think we should be moving toward.
That sounds fantastic. I love that idea. So our little rheumatology utopia. And I think the message here is knowledge is power. And Devin also commented to say that, he's learned that silence is not good. It's a slippery slope and you feel alone. Communication with family, your partner is very helpful because those close to you don't know how you feel. What is your current pain levels? What is your mental state? And your rheumatologist also doesn't know unless you tell them. And Devin also just really wanted to thank you, Dr. Ziki, for all your input and wisdom that you shared with us today.
Yeah, thank you. It's always a pleasure. Like I said, I learn from other people. I learn from my patients.
Well, we love having you here, Dr. Ziki, and I know that you are eager to get back to your little breakaway. So I think that all that's left to say is how much we appreciate you. I mean, what other doctor is going to sacrifice an hour of her weekend away to come and talk to us? I think that's fantastic. And it really shows your care and commitment, Dr. Ziki. And we really are very, very grateful to always be able to get a little slice of all your knowledge and wisdom that you share with us.
Thank you. And enjoy the rest of the day. I'm going to get back to my family.
You do that.
I'm doing nothing this weekend.
Enjoy. Do nothing. I heard a very clever doctor say that it's so good for you.
Yes, doing nothing.
Yes.
All
Thanks,
right,
Dr.
guys.
Ziki.
Thanks.
Take care.
Enjoy the rest of the day. Thanks.
Thank you.
Thanks.
Bye.
Bye. Bye.
Okay, guys, we're just going to take a quick comfort break. Um, we will start with our next session at 10 past 10. I almost said 10 past 9. Um, so if you want to stretch your legs, grab a cup of coffee or a glass of water, um, we'll reconvene, and then we're going to be talking all about the gut, which is something that Dr. Ziki mentioned as well. So I think it will tie in quite nicely with her talk. So yeah, go stretch your legs, do nothing for 10 minutes, and we'll see you soon. Hi, everyone. Can you see the presentation? Francis?
I can.
You can. Okay.
Yes.
Okay, great. Is everybody back? Okay, so Sister Frances is going to talk to us about the gut and Axpar. She is an IBD nurse and also an infusion specialist. Um, she's attended many conferences throughout the years, and she was actually introduced to gut health by Dr. Peter Barrow. Sister Frances, thank you so much for joining us this morning. We really appreciate it, and we look forward to all the wisdom that you are going to share with us regarding the gut.
Morning, and thank you so much for having me. Can you all hear me?
Yes,
Tanya?
definitely.
Can you hear me?
Yes,
Perfect.
yes.
Perfect. Thank you. Good morning, and thank you so much for inviting me to join you today to chat this morning. My name, like Tanya said, my name is Sister Frances Harris, and I run an infusion center at Melrose Surgical Center, where I mainly do biologic and iron infusions. I previously worked for Dr. Peter Barrow at Donald Gordon Hospital, where I assisted him with his gastroscopies, colonoscopies, video capsules, and infusions. And I got to help treat a lot of his patients and learned a lot about IBD. The reason I'm putting this in is just so that you know I have done a little bit of research into IBD over the years. So it's not just, I'm not just here because Tanya couldn't find anybody else. I have an incredible respect for patients and people who are advocates of their own disease. Dr. Ziki brought that up, and it's really, really important. There is nothing more frustrating than meeting a patient who has no idea what their medication is or why they're taking it or what it's for. I take a little green tablet in the morning and I take a blue tablet in the evening, and they're actually unaware of why they're taking it. So patients need to know about their disease and ask questions and ask about side effects of that medication. They don't just yard doc, okay, doc, whatever you say, doc, find out what the side effects are, find out why you're on this drug and what it's for. So groups and talks like this are wonderful. It gives us all a chance to learn more about our diseases, your diseases, and living with this disease to the best of your ability, which is exactly what I believe Tanya was wanting to achieve this morning with this talk and with the people that she's chosen. So, Tanya, can you move on to slide 2? Sorry, my technical abilities are not as good as my nursing abilities. So first, before I start talking about what I'm talking today, is I want to make this, if you have any questions in between, please just shout, put your hand up, whatever, let us know. I don't want to carry on if we've got questions because it is a little bit of a detailed subject. So Tanya's given me a bit of a guide on what you want me to talk about today, and I'm hoping I can assist. Because I'm not a doctor, I speak to patients and people, I tend to dumb things down a little bit, try and make it a little bit more simple to make it make more sense. Please feel free, like I said, to interrupt me. There are no stupid questions. There are questions that other people are mainly wanting to ask. There's only stupid answers. So Tanya, slide 3, please. So what is an autoimmune disorder? As I'm sure you know, there is a long list of autoimmune disorders, and ankylosing spondylosis and IBD are on that list. Patients who have an autoimmune disorder often have more than one autoimmune disorder, and this can affect joints, skin, liver, thyroid, etc. Slide 2, please. This is a tricky slide, so to explain, so I'm going to do my best. So some of these diseases are clustered together, all right? And one of the most common clusters that we have is this slide that I'm going to give to you now, but it's the IBD and the spondyloarthritis cluster. All right. So that is when you've got your Crohn's disease, your ulcerative colitis, and your ankylosing spondylosis, all and psoriatic arthritis, got tongue ties of note, all moved in together. Tanya, can you go to slide 5 for a second, please? This is quite a detailed slide, and I don't expect you to understand it because certainly most people don't, most medical people don't, but they bring this up in every single autoimmune talk. It's a slide that just shows you all the different aisles. So when a doctor refers to an aisle, which is what I will be referring to now, means that that is the channel that the diseases are taking. Okay. And in saying that, can we go back to slide 4, please? This is important to remember when your diseases are being treated because you've got shared pathways. So your anti-TNF alpha and your IL-17 and IL-23 and gut joint axis are all joined on the same aisle. Okay. Some biologic medications treat more than one pathway or aisle, and some are specific to just certain pathways or aisles. For example, some only treat the gut and some treat joints. I have some patients who have Crohn's disease and ankylosing spondylosis, or they've got uveitis and Crohn's disease, or they've got eczema and Crohn's disease. Finding the correct treatment to treat all of these can be a struggle, as what treats one may not treat the other. So what treats your Crohn's may not treat your ankylosing spondylosis, or what treats your ankylosing spondylosis may not treat your eczema. So does that make a little bit of sense? Anybody got any questions on that? All right. So when it comes to treatment, the number one rule is do no harm. So the challenge is working out when a patient has a joint issue and is on treatment and then develops gut symptoms or skin inflammation. Is this the treatment that's causing these extra manifestations? Is it a side effect to these treatments, or have you been blessed with more than one autoimmune disorder? Okay, if nobody's got any questions, we'll go on to slide 6 now, please. Okay, so now I'm going to explain to you a little bit about what IBD is. IBD is inflammatory bowel disease. Crohn's disease can affect any part of the digestive tract from your mouth to your anus. Ulcerative colitis only affects the colon and the rectum. What happens in IBD is the immune system, just like with your joints, becomes overactive and causes swelling of the bowel wall, ulcers, and bleeding. Long-term damage to the intestine is detrimental. And you have periods of flares and remissions, just like you would with your joints. All right, so let's go on to common causes. This is what you should not be ignoring. These are common causes of IBD. Persistent diarrhea, blood or mucus in your stools, abdominal pain and cramping, fatigue, that lovely one that Dr. Zicki said, weight loss and anemia. Anemia is incredibly important for us. Slide 8. Now, when you go to your rheumatologist and you are now experiencing abdominal pain, bloating, diarrhea alternated with constipation, occasional blood in your stools and reflux. You go to your rheumatologist, which you've now waited weeks for. As we all know, they're incredibly busy and we respect that. And he or she says there's nothing to worry about, or he or she says you need to see a gastroenterologist. You call the gastroenterologist rooms and you have to wait a further 2 to 3 months. In the meantime, should you be panicking? Should you be panicking? Stephanie, I will go through that question with you just now. So I'm going to go through this because rheumatologists love to do blood tests, and blood tests are imperative to monitor all diseases. So when your rheumatologist says that you need to see a gastroenterologist, but he or she has done these blood tests, okay, you'll see that she or he has done a full blood count. Now, when we're doing that, we're monitoring to see if you've got raised white cell counts or if you've got anemia. If you've got CRP levels are invaluable. They tell us if you've got inflammation in your body. Your iron studies will tell us if you've got bleeding somewhere. Your urine will tell us if you're dehydrated. Your liver tests will tell us if there's any liver issues. And your vitamin B12 will tell us, and your vitamin D and folate will tell us if there's any deficiencies there. So if any of those are low or are not in the right margins, you need to have them investigated. Another beautiful tool, which a lot of people don't use as much as we would like them to use, but we love this test, is a stool sample. The stool sample, there's 2 tests that you can do with a stool sample. Well, there's multiple tests, but the most useful one is one called a fecal calprotectin. This is incredibly useful because it will show us if you've got inflammation in your colon. So when your CRP levels are elevated and you've got inflammation in your body, that is one thing. But a fecal calprotectin will tell us if you've got inflammation in your colon. So you'll see here I've written in there a normal calprotectin for somebody like myself who does not have IBD is below 50. Mildly raised is between 50 and 150. That shows us that you've got a possibility of inflammation. Not too alarming, but some investigations need to be done. If it is above 150, and it can go as high as 6,000, so it gives you a little bit of an idea, we're looking at, when it gets to 6,000, then we're looking at immediate admission. So you can get a bit of an idea that if your calprotectin is not mildly and not elevated too high, you don't need to panic. All right. The second thing that is always invaluable when you've got persistent diarrhea or stool or gut issues is doing a stool culture. We all get tummy bugs. Everybody gets tummy bugs. And a stool culture can rule out all manner of stool infections that other people may not have realized you had. And a simple antibiotics could actually solve that problem. The second one, which we all are aware of, but not always rheumatology patients, is a C. difficile test. Okay, so that's Clostridium difficile, and that is a very, very important test because patients who have got low immune systems, so particularly patients who are on high doses of steroids or they're on immunotherapies, all these sorts of things, they are highly susceptible to a C. difficile test. Let's have a look here. Stephanie, what have you asked? I want to ask if a gastro can develop from IBD. Oh, gastroparesis. We'll go through that. Is it possible that you can have constant low inflammation in your colon, but inflammation in your CRP are always low? Yes, it is. And that means that usually it's not anything to worry about. Okay, so this is what I'm saying is if these levels are low, then usually it doesn't mean that you've got any problems. Okay, but it doesn't mean you don't have any problems. It means that it's unlikely that it's a serious issue. And when I say serious, I put it in inverted commas because when you've got persistent diarrhea, it's a serious issue in your life. But when a calprotectin is normal, it means that we're not too worried about IBD or tumors or something like that. Okay. Does that make sense? Any questions? No. Okay. Now, can we move to the next one? So when we look at our gut-brain link, so when things are not serious, but they are serious in your life, there is always a gut-brain pathway that we know is linked. So now I'm not just brushing you off, I'm explaining that you have got issues with your tummy, you do experience bloatedness, you are experiencing these overactive tummy where one day it's constipated, the next minute you've got diarrhea, then you don't go to the toilet for 2 or 3 days, and you've got this bloated feeling like you're highly pregnant. This can be affected by the brain-gut link, which is very much exacerbated by gut microbacteria that's not working properly, stress, and we call it IBS. So that is irritable bowel syndrome. And this is when your bowel system becomes overactive. And I found this saying, which I thought was really, really quite clever. Your bowel looks normal, but the communication between your brain and your gut is overactive, which means your gut is more sensitive to normal things like food, gas, or stress, which can cause bloating and pain. All right. Any questions on that? Can we go to the next slide, please? Okay. So common symptoms of IBS are your abdominal pain, alternating bowel habits, and bloating and distension. Okay, so these are not taken lightly, but when we explain these, we need to explain that abdominal pain, we do not have pain receptors in our colon and in our tummy. So when you're feeling that you have got excruciating pain in your stomach, it's usually from a blockage of some sort. Now, this blockage can be food, it can be a tumor, it can be, so in other words, it can be serious, or it can be from gas. All right. And gas can cause an exceptionally large amount of pain. We're all aware of that. We've all had an episode of gastro where you feel like your stomach is on fire with pain. But it is the bloatingness of the tummy that's not happy. It's not a happy gut. And as a result of this, everything is inflamed and it's not happy. And that gas can cause an exceptionally large amount of pain. All right. Can we move on to the next slide, please? Important, but not red flags when we're looking at, important, not IBS. These are warning flags for what an IBD patient should be looking out for. All right. So when when it is not IBS, okay, blood in the stool, unexplained weight loss, fever, nocturnal diarrhea. So that's when you wake up at night to go to the toilet to pass diarrhea, and you have this urgency to go to the toilet. Anemia, which is your low iron, raised CRP or a raised fecal calprotectin, persistent with severe symptoms or family history of of IBD and bowel cancer. So those should never be ignored. Those symptoms, we need to look into that. So now the rules when it comes to, I'll answer that question for you now. So when it comes to colon cancer, if there's family history of colon cancer, you need to start doing your colonoscopies and gastroscopies from 45 years of age. For routine patients who have not got family history of colon cancer, you need to do your colonoscopies from 50 years of age. And these should not be ignored, just like we go and have our mammograms done when we reach a certain age, and we go and see our gynaes for our pap smears, and men have their PSA blood tests. It's important that you have a colonoscopy and a gastroscopy. Don't just ignore these things, and they should be routine in your life. All right. Now, somebody asked a question about when is anemia alarming? Now, anemia, I do a lot of iron infusions and I attend a lot of talks about iron. And iron is a great tool for us to see what's going on in your body. All right. So how often, I'll explain that to you now with the colonoscopies. So iron is a great tool. So when we're looking at, just want to look at something. When we're looking at a gastroscopy and a colonoscopy, I seem to have lost. All right. So when we're looking at a gastroscopy and a colonoscopy, I'm sorry, I seem to have misplaced that slide on here. We're looking at various things. So when you have a gastroscopy and a colonoscopy, your gastroenterologist or your general surgeon is going to do a scope. The gastroscopy goes down your mouth all the way to the first part of your small intestine, which is known as your duodenum. He is going to look for reasons why you could have anemia or bleeding, or you could have any bloating and gut issues in your gastroscopy. So he's looking for in your esophagus, he's looking for erosions in the esophagus, which could develop as a result of reflux and can actually develop into something called Barrett's. He's looking in your stomach for something called H. pylori, which is a bacterial infection which causes severe gastritis and bloating, and that can be easily treated with antibiotics. He's looking for gastritis, which is redness and inflammation of your stomach, and he's also looking for ulcers. Now, you patients generally, no disrespect, but patients who have joint problems are usually on high doses of cortisone and also, very importantly, on high doses of anti-inflammatories. So cortisone and anti-inflammatories can cause ulcers and gastritis in your stomach. And those ulcers and gastritis can bleed. Okay. Obviously, we do get terribly bad ulcers where they bleed horrifically and patients start vomiting up blood and they can die from that. So when that happens, you need to get medical help straight away. So people will often go, I've got a stomach ulcer. I've got a stomach ulcer. I can feel my stomach ulcers flaring. Don't just say that. Have it looked into. Because if you really do have a stomach ulcer, it needs treatment. You don't just ignore a stomach ulcer. A stomach ulcer can cause bleeding and it can cause severe bleeding. Like I say, it can result in vomiting up of blood, and you can actually die from that. So you don't just ignore a stomach ulcer. You need to have it looked into, and you don't just go on reflux medication unless, of course, it's been investigated first. So that is what we're looking for. Then the gastroscopy will go down as far as the first part of your small intestine, which is known as your duodenum. And that is where we're looking for something called celiac disease and also ulcers. Celiac disease is another autoimmune disorder and can also occur. And celiac disease is when those little villi, I always say when we go back to our anatomy and physiology, we got our villi, which are in our small intestine. And those villi will show us when we have got, so if you go back to your anatomy and physiology, when we did biology, your villi in your small intestine, when you've got celiac disease, they are stumped and they lie flat. And a result of that, you don't absorb as much nutrition. All right. And that usually presents as weight loss, anemia, and vitamin B deficiency. So there's another thing that we're looking for. So that is what we're looking for when we're doing a gastroscopy. When we're doing a colonoscopy, the colonoscopy will be done where the jolly great big pipe is stuck up your bottom after you've done a horrific 2 days of clean prep. But the reason for the horrific 2 days of clean prep is to clean out your colon so that your doctor can look carefully at all the nooks and crannies in your large intestine. It only goes as far as the terminal ileum, which is the last part of your small intestine. And what he or she is looking for when they're doing that is they're looking for ulcers in your terminal ileum to rule out things like Crohn's disease. So also, those ulcers, when they're there, they can show malabsorption, they can bleed, and they can cause that sign of anemia and obviously diarrhea and fatigue that comes with it. Then he's going to, or she is going to look at your large intestine, and in the large intestine, they're looking for general inflammation, which could be ulcerative colitis, polyps, and tumors. And then last but not least, they look at your rectum to work out if you've got any hemorrhoids. Because yes, hemorrhoids also, as much as they're not that exciting, hemorrhoids can cause anemia, they can cause blood in the stool, and they can cause constipation. So that is what we're looking for. And that is why, just because you're experiencing all of this, a colonoscopy, I hope that explains it to you a little bit more clearly. Any questions? Okay, no, just want to see where is it. Tanya, can you see where that question's gone? I think it was about anemia. Okay, so I think it was from Aisha. So Aisha, I've taken in, when it comes to anemia, anemia is one of those things that has become more and more not prevalent, but more of a topic of conversation nowadays. The reason for it is because a lot of us women have lived with anemia for all our lives. Ever since you started menstruating, you developed anemia. So a lot of people just went, oh, women have got anemia because of the fact that they menstruate every month. Women have got anemia because they don't eat red meat. Women have got anemia because they're vegetarian. It's just the way it is. And yes, it can be one of those three things, very much so. But we don't just ignore anemia. We don't just brush it off. Anemia causes horrific fatigue in our community. 50% of women living in sub-Saharan Africa have anemia. 50%. That's 1 in 2 people. 1 in 2 women have anemia. And you don't have to suffer with fatigue and all that goes with anemia, because of the fact that you have been told you're anemic and it's just the way it is. Take your oral iron supplement and you'll be fine. Because anemia is not just one of those things. It's easily treated and it shouldn't be ignored. So your signs of anemia, I wasn't going to talk about this, but because it's important, and definitely with the topic of fatigue that Dr. Ziki brought up earlier, anemia signs and symptoms are fatigue, hair loss, restless legs, dry skin, brittle nails, and it can actually, some people manifest when they eat ice or they eat sand. So anemia is very common. We generally look at it more in pregnant women, and we tend to forget about it in our chronic ill patients. But fatigue can be very much alleviated if you have proper treatment of anemia. And that is by, if you take oral supplements and your iron levels are not improving because of the fact that you're not absorbing the iron, or because of the side effects of the iron, then an iron infusion is always very, very is encouraged in the right setting, which is in a medical environment, because a lot of doctors are nervous of iron infusions because of the anaphylaxis. So I've gone through that very, very briefly, but I don't want you to ignore anemia. Okay, so anemia can be an underlying cause of lots of different things, like I said, hemorrhoids, celiac disease, IBD, but it can also be you have a tumor in your colon. It can be lots of things. So don't ignore anemia, but also don't panic. It can be because you're vegetarian, you don't eat a lot of red meat, you don't absorb iron, or you are menstruating every month. Any questions on that? I hope that made sense. All right. Can you move on to my next slide, please? Next one. There we go. So in saying all of that, I hope that that's explained a little bit about IBD, when to panic, when not to panic, and take into consideration that IBS is a real disease. IBS is associated with anxiety, and with IBS comes all manner of complications. And treating IBS is a lot more difficult than treating IBD. IBD is a disease that needs to be treated properly. IBS, unfortunately, is associated with anxiety, and it is very much gut and diet and anxiety related. And it's a really, really hard disease to treat. I hope that all makes a lot of sense. Here's my email address, which I've managed to successfully put too many S's in. So it's infusion with an S on the end at gmail.com. I'm infusions, JHB, but it's not at gmail.com. I'm very happy to help and answer any questions if I haven't answered them here. I am an IBD and an infusion nurse, so I cannot ever diagnose things, but I can advise, and I can't prescribe things, but I can advise. And I'm very, very passionate about patients and patients advocacy and looking after patients who have chronic illnesses, because I think they often are not necessarily given the right time when they're in a consult with their doctor because they're overwhelmed, or their doctor looks at the bloods or looks at the stools and goes, your bloods were fine, your stool was fine, but guess what? I don't feel fine. And you haven't answered my question. Yeah, but everything's telling us you're fine. Yes, but I don't feel fine. And it's those sorts of situations that everybody finds really, really frustrating and very, very tricky. So on that, I'm going to say thank you very much. I'm open to any questions. Like I say, there are no stupid questions. Has anybody got any questions?
I'd like to know if you've got any advice on how to improve your gut health.
Yes, I
I
do.
know Dr. Ziki mentioned yogurt and kimchi and that sort of stuff, but yeah.
So probiotics, I mean, there is a lot of buzzword. The probiotic story has reduced quite a lot. So, 15, 20 years ago, everybody was told that probiotics was going to save their lives. Good gut health is way more important than a probiotic. Probiotics are a little bit in the IBD environment, a waste of money and time. The time when you use a probiotic is when you're on an antibiotics and you need to use a good probiotic. The second time to use a probiotic is when you feel it helps your tummy. So if you take a probiotic and it is helping your symptoms, then don't stop it. All right. So it's one of those ones that you can take it, but for good gut health, the most important thing you can do is eat lots of different fruit and vegetables. They say, Dr. Barrow did a talk last year for perimenopausal women, and you're supposed to eat between 30 and 50 different fruit and vegetables every week. Now, 30 different fruits and vegetables every week is not easy. We can all eat an apple a day, a banana a day, but do we eat kiwis and cauliflower and broccoli? So for good gut health, they say the best thing to do is vary up your diet and eat lots of fruit and vegetables and different fruits and vegetables. So the people with the best gut health are the people who live off the land, which we don't. So there's actually a village in India, North India, and they've got, apparently, according to an Indian doctor who I attended one of his talks a few years ago, they have got the best microbiome gut health that they've ever found. And it's because people who are living off the land. So you probably find people who eat fruits and vegetables as opposed to red meat have a much better gut health. They also people who don't eat processed foods. So processed foods are a big no-no. So that is what happens in a lot of our yogurts and stuff. A lot of those, when we're buying them, I think a lot of that microbiome has been killed. So I would do, if I was going to rely just on yogurt, I would probably go to a health shop and read a little bit about it and find the best one, which has got the best probiotic in it. And exactly like Dr. Ziki said, the buzzword is, it used to be FODMAP. FODMAP's gone out the window now. The new diet that we like and we recommend, and it's been going on for a couple of years now, is the Mediterranean diet. So the Mediterranean diet is invaluable. And if you look at people who live in the Mediterranean, we keep seeing these YouTube videos of little old ladies and little old men who live in little villages in Italy and Greece and things like that, and they're eating their olive oil, they're eating their fresh fruit and vegetables, and they're eating fish. And that is what it is. It is not the Western diet, okay? Processed foods, processed pizzas, processed meat, processed cheeses, fake creams, all those sorts of things are what's killing our diet and our good gut health. Does that answer your question, Tanya?
Yes, thank you. I just also wanted to ask, there's a lot of hype at the moment around fermented foods, the kombuchas and the sourdough bread, and it, is that just a hype, or is it
No.
really something we can benefit from?
Yes, and obviously your sauerkraut. Everybody loves sauerkraut at the moment. Again, exactly like Dr. Zicki said, there's not one size fits all. Okay, so if you like kombucha, great, give it a bash, and if it helps, great. If it doesn't, stop it. Okay, same as sourdough. Most people struggle with bloating in their stomachs. And when I used to work with Dr. Barrow, it was a very frustrating phone call when I would phone somebody and say, "We got your celiac blood results and your biopsy results, and you don't have celiac." And they go, "What do you mean I don't have celiac? I've been told all these years I'm gluten intolerant." I didn't say you weren't gluten intolerant. I said you don't have celiac. So we've got to also differentiate the difference. Just because you don't have celiac doesn't mean that you're not gluten or lactose intolerant. If milk does not agree with you, don't drink it. If white bread doesn't agree with you, don't eat it. Those are when we are gluten intolerant. So that is why sourdough and your kombuchas and all of that are very popular at the moment. But if it irritates your gut, don't eat them. All right. You've got to find what works for you best. But don't break the bank on a probiotic and don't break a bank on all these exciting things, and read the ingredients. I preach it, I don't practice it, but read the ingredients on packaging and ensure that what you're buying is what you're getting. All right. Does that answer that question for you? When
It
should
does, yes.
I love this question, Candy. Thank you. When is a capsule endoscopy a consideration? Okay. So, and somebody also asked, how often should we do colonoscopies? Okay, so the first one is, like I explained to you, with a gastroscopy and a colonoscopy. A gastroscopy looks from your mouth to the first part of your small intestine. Your colonoscopy from your mouth to the large part of your last part of your small intestine. We have now got meters of small intestine in between, which have not been looked at. So when you have got anemia or IBD symptoms, all right. So if you've got anemia and they know you're bleeding from somewhere, and it's not from gynae, and it's not from your they couldn't find it in your gastroscopy and they couldn't find it in your colonoscopy, then they will look at doing a capsule endoscopy to do it where they rule out if there's any small ulcers or broken vessels in your small intestine that could be causing bleeding, or in the case of Crohn's disease, where they can pick up more Crohn's disease. So that is when a video capsule should be considered when you have got anemia, your vitamin B12 is low, your calprotectin is elevated, your symptoms haven't been relieved by general treatment, and a colonoscopy and gastroscopy has been ruled out as normal. All right. So I hope that answers that question. Then the next question was, when should a colonoscopy done after 50? So after 50, it is done. That's your first one. Okay. If your gastroscopy was normal, you should not need to repeat it again unless, of course, you become symptomatic, like you get reflux or anemia. Your colonoscopy depends on what they found on the first one. So if they found nothing on the first one, then you can repeat it in 10 years' time. If there's family history of colon cancer, then you need to repeat it in 5 years' time. And if you've got a polyp, It depends on what that polyp was. But generally, if you've got polyps, you repeat it every 3 to 5 years. Depends on what that polyp was. If the polyp was a tubular adenomata, which could have become cancerous, then you need to check it every 2 to 3 years. Does that answer that question for Stephanie? I see, Ayesha, I found your question now. When is anemia alarming? I do iron studies done, and it's currently on an iron supplement, and I've still got low anemia. So there's your answer. And you're on an iron supplement. When it comes to iron supplements, they're a tricky one, because it's what time of the day do you take your iron supplement? So milk kills iron supplements, coffee kills your iron supplement, and cereal kills your iron supplement. So in the morning is not the right time to take an iron supplement. In the evening, if you're not drinking coffee and it doesn't contradict with any of your medication that you're taking, you can take an iron supplement before bed, or otherwise the best time to take it is in the middle of the day at about 11 o'clock. Iron supplements are not taken every day. They changed the rules about 10 years ago. They did research and they found out that iron supplements should be taken every second day, and that increases your absorption. So yes, if an iron supplement is not bringing up your iron levels, then it's best to look at doing an iron infusion. Does that answer all those questions? Anybody else got any questions?
Yes, it does. Thank you so much, Sister Francis.
Pleasure. I hope that was helpful. Anything else, Tanya?
I don't have anything from my side. I think that you've shared so much information today, and it was really, really interesting. No, but you shared it in a like you said, a dumbed down way, which makes it easy for us to understand. Yes.
Yeah. Good.
And because otherwise, if you come with all these big medical terms and stuff, we are not doctors. So yeah. And I think even the information about the iron, that you've just given is invaluable, because so many of us do struggle with anemia. And personally, I'm going to have to revisit when I take mine, because I take it in the morning and I drink coffee. So
yes,
clearly that's something I need to look at.
Exactly.
So it's really been so interesting.
Yeah, and iron is absorbed with vitamin C and vitamin B. So if you've got low vitamin B levels, then your iron's not going to be high. So it's all these sorts of things. And this is why I always respect a rheumatologist who refers a patient for a gastroscopy, because they need to rule out all these things. But you can see what I mean when I say a blood test can rule out the urgency of having this done. So it's another thing. Somebody was just asking, how often should you do an iron infusion, and how long do they last? That's a good question. How long is a piece of string? If we've removed the problem, so when you've got low iron, now this is suddenly become an iron talk. When you've got low iron, you've got to work out why you've got low iron, and you've got to replace that iron. So now, if we've worked out why you've got low iron, and we stop that, then that iron infusion should last you for at least a year, or if forever, because you've stopped bleeding. Okay. But if you carry on bleeding, as in lack of absorption because of your disease activity, or the medication you're on stops you absorbing iron, or you're a vegetarian, and as a result of it, you don't eat a lot of red meat, and you can't, and iron supplements irritate your tummy, your gut, so you can't take them, then you might need to do an iron infusion every year. I had a lovely little old lady who is still alive, actually. I found out the other day, I saw her nephew. She must be about 88 now. And we diagnosed her, Dr. Barra and I, on a small capsule, diagnosed her with a tiny little blood vessel in her stomach, in her small intestine, which was bleeding. And it dripped like a little tap. Okay, so you can imagine that if you've got hemorrhoids, they can also be dripping like a little tap. If you've got an ulcer in your stomach, it can be dripping like a little tap. Same as these little broken blood vessels. And if that bleeding doesn't get under control, you're going to need to repeat those iron infusions. But if you can find out what's happening there, then at least, so she used to come to me every year, then it became every 6 months, and eventually we had to do surgery to cut out that small section, and then she never came back for another infusion again. So when you have an iron infusion, we always check bloods 2 months afterwards, and then we tend to check them every 3 to 6 months. All right. But again, you've got to be an advocate of your own. So you've got to look at those blood tests and understand them. And if you don't understand them, ask your doctor to explain them. All right. The Ampath and the Lancet app are generally quite helpful at giving you those blood results. But otherwise, ask your receptionist at your doctor's rooms. They're your blood tests. They're your scope results. They're your MRIs. You're allowed to have a copy of them. Nobody owns them except you. So ask for them and ask for them to be explained. Did that answer that question? I could go on for hours, Tanya.
No, this is really amazing. And the one thing I hear that keeps coming up is listen to your body. You know your body better than anyone else. And if you feel that something isn't right, don't just leave it. Investigate it. Find out what is going
Exactly.
on.
Exactly.
You know, a lot of us in this particular, well, in my particular age bracket, you know, if we're tired and we've got an autoimmune, and then the doctors are like, oh, but you know, you're also menopause, you know, so it's also the hormones that's making you tired.
Yes.
But if you feel like, no, I know this is something else, and that's what I did. I was like, no, I know this is something else. And I did the bloods, and it turned out that it's my iron. But listen to your body. I think that is crucial. Listen and then talk to your doctors. Tell them what you are experiencing. Don't feel like you can't say anything because you are not the doctor, you're the patient.
Yes. And there's an amazing talk. There's a wonderful lady called Lauren who does a talk on advocacy. And you should see her in a room full of doctors. She will talk about patient advocacy and being a patient advocate and a patient being an advocate for their own disease. And there'll be deathly silence in the doctor's rooms because, and everybody thinks that a doctor gets offended when a patient comes in as a know-it-all. They're not offended. They would rather have somebody who has done a little bit of research and found out that maybe, you know what, I think I might have low iron, doctor. Yeah, but why? Well, I've got fatigue, my hair's falling out, and this, and you know, these sorts of things. And then, okay, well, let's do a blood test on you. Done. It's done. That was a 5-minute conversation. And instead of beating around the bush, you know, I don't know what's wrong. And ask, ask the intelligent questions. Be an advocate for yourself. Doctors appreciate an advocate. They really do. They don't think of you guys as know-it-alls at all.
Is there any other questions, guys?
Because I know you've got to go on to your next meeting.
Well, we're going on to a break now. So if there's more questions, then we can have a look at them.
And Tanya's got my email address. Look, I'm not great at admin. As you can see, I'm shocking at slides, but I'm great at talking. And I can help, and I'm happy to help. I cannot prescribe, I cannot diagnose, but I can advise. And that is what nurses are there for. We're there as advocates for our patients. And you'll see that a lot of gastroenterologists have got nurses, or they've got now what are called new ones are clinical associates. But the reality is that doctors can't do it all. They don't have enough hours in the day to answer all the emails and the questions. So I'm going to leave you now if there's no more questions. Have a beautiful rest of your day and ankylosing spondylosis day. And thank you so much for the privilege of this, Tanya. I really do appreciate it.
Thank you so much, Francis. We really, really appreciate your time on this long weekend Saturday. And I just want to ask, can you perhaps pop me the details of the advocacy lady, the Lauren that you spoke of? I think
I
it
will
would be good to
definitely.
get her in at
Yeah,
some stage as well. Much
she's lovely.
appreciated,
Yeah.
Francis. Have a beautiful, beautiful weekend. Guys, anything else from anybody, or are we ready to take a break? Okay. We've got a bit of time before Mia joins us at 11:30. At 10:30, sorry. So I think if you guys want to quickly grab a bite, grab another cup of coffee, except if you've just taken your iron tablets, and then we'll see you back just before 11:30 so that Mia can tackle the whole mental health portion of our day. Is everyone back?
Oh, I'm here.
Hello, Charlene.
Hello.
Is everyone enjoying the day so far?
I have found it very informative, and specifically also the whole holistic. I've really, even though you do your own investigation, there's always something new that you haven't thought of. I don't know. I found it great.
Yeah, I think it's a case where you can always learn more, right? Yeah, I think most people are back now. I'm really excited to welcome Mia, who is a registered counselor. She's got 2 honors degrees, a master's degree in psychology, and with a special interest in the neurobiology of trauma and living with chronic pain and illness. So Mia really helps individuals to better understand their internal experiences, and she then uses evidence-based tools to empower people, her clients, to regain a sense of control and direction in their lives. And because of her special interest in chronic illness and chronic pain, I think she is going to definitely be able to share with us the impact, the mental health impact of the disease, which I think a lot of people don't understand or underestimate. Mia, all yours. Mia, I can't hear you. Can anybody else hear Mia?
No.
It doesn't look like you're on mute, but we can't hear you at all.
Yeah, it's my speaker, my headphones. You can hear me now?
Oh, yes, we can.
Okay, all right, excellent. Okay, all right, and you can see my slides?
I don't see them. It was there before
Was
during
there?
the
Let's
break,
just
but
try
it's not there
again.
now.
Window. Share this window. Okay, can you see that?
Perfect, yes.
All right. Okay, everybody. Thank you so much for having me. I'm really excited to be here with you guys today, just learning and really trying to understand better what this world of autoimmunity is like. So in our conversation today, I want to where are we? There we go. I am just going to introduce the kind of information that I'm sharing with you today. I want to then unpack a little bit the interior landscape of chronic pain, what's going on inside when you're experiencing this kind of chronic pain, the ripple effects of chronic pain, and how far they reach into our lives. And then I want to see if I can convince you to reclaim and change your narrative, and see if I can convince you about the power of that kind of thinking when you are living with chronic pain and illness. And then I will definitely leave some time for questions and discussion. Everybody, the research is showing that community building is one of the most effective ways of doing mental health care, because humans are herd animals. That's how we're wired to operate. So please do share your reactions, your responses. You'll see on the Zoom platform, there's a little space where you can give a reaction. Please use the chat box as we go. If you feel like you can relate to something, say it. If you feel like you disagree with something and it sounds completely unrelatable to you, say it. Yeah, please post your questions there. I can't see them at the moment, but I'm sure Tanya will help me to look at those questions. So everybody, most of the time when I hear stories of living with chronic pain and illness, I hear stories of being dismissed. I hear stories of not being believed, being gaslit, sometimes by doctors, being gaslit by family members or employers. Lots of people saying to people living with chronic illness, at least this, and just be grateful for that, right? People sort of preaching at you about the power of positive thinking. Just think positively. And yeah, I'd love to hear from you guys, but I've never had a positive experience of being told just think better. That really doesn't work for me. So I'm hearing these stories, people living with chronic pain and illness, and they're living in states of survival, just survival mode, intense self-criticism going on, intense feelings of powerlessness, of hopelessness. And I hear people telling stories of not being good enough. I'm not doing well enough at living with chronic illness. People living in shame and exhaustion while they keep trying to do better. I hear stories in which people are really positioning themselves as if they are the villain in their story. They are the one who is doing the wrong thing. They are the one who is messing up. Or in their story, they are the victim, this desperate, hopeless, powerless person who doesn't feel like they can take direction. People feeling trapped. Now, while people are telling me these stories, though, I'm hearing something completely different. I'm not hearing pitiable victims who can't get it right. I'm hearing experts in resilience who are doing more with less. I'm hearing tenacity. I'm hearing refusal to give up, refusal to sacrifice your values of not becoming an aggressive, lashing out person or whatever is important to you. I am hearing a quiet endurance of something that's real and valid and deserving of attention. So, as we go into the mental health side of things, please just take a moment to gently and with curiosity, not self-criticism, but curiosity, just zoom out a little bit from your story and think about how it is that you tell the story of your chronic illness? Do you tell it in a way in which you are in the wrong? Or do you tell it in a way in which you are a fearless hero surviving no matter what happens? After you've heard what I want to share with you today, you might want to rethink the role that you cast yourself in, maybe even what genre your story belongs to. Just gently zoom out and see how you feel. So, everybody, in the first place, I really just want to acknowledge the weight of what we can call performing wellness. So, this is all of the energy that goes into acting as if you're not in pain, acting as if you're not fatigued. So much energy can go into filtering yourself, policing the words that you say in front of other people because you don't want to be a downer or you don't want to burden them. And so you have to filter yourself all day long to decide what you are going to say and what you're not going to say. The energy that goes into acting cheerful, it's Mother's Day, and so it's time for everybody to come around and have a beautiful brunch together or whatever, and that's great, but you feel horrible. And so now another wave of energy has to go into the performance of me being okay enough to participate. Trying to explain again what's going on for you. So the mental load of managing constant pain, managing constant fatigue, and the 50 other things that you have to remember in one day to, stay stuck with your medication regime, to find some comfort throughout the day. It's such a huge toll on the system. And that is something that can be difficult to articulate to other people, even difficult to recognize in yourself because you're fatigued. So, when other people have not been through chronic pain and illness, I think a really, really difficult thing is that they can't conceptualize it. They don't have a frame of reference. They don't have the experience of what it's like. And so there can be really, really uneven expectations, and a lot can go wrong just there. So we have all of these people who have no conceptualization of what it's like. And they, even when they intend to help you, they can leave you with a sense of pressure to act in a certain way, to speak in a certain way, all kinds of things like that. And I think that, one of the consequences of this performance of wellness is that it can leave you feeling really, really lonely in your experience of illness. Like there's no one who you can just moan to. I mean, quite literally, sometimes with my chronic pain, I literally just want to just moan a bit. And, sometimes other people don't know what to do with that, and they panic and they freak out. And I'm like, I just want to lie here and do that a little bit. So we can end up feeling very, very lonely. If we look at the kind of psychological pattern that we're likely to see in response to all of the physical nastiness and everything that's happening within your psychology, a very common pattern, I would love to hear from you guys whether you can relate to this, is what we call the boom-bust cycle. Oh, my headphones just did something. Can you still hear me?
Yes, we can.
Okay, excellent. All right. Okay, so the boom-bust cycle, in which we are essentially switching from hectic busyness to collapse and back and forth the whole time. That's what we're doing. So we have this stoic, ableist kind of society in which we are taught from very young to get on with it, get over it, avoid the self-indulgence of emotions, something that's quite difficult for me as a student of psychology to understand. We are taught that being busy doing a lot of things is the right way to be. And then we also live in a society that overuses and sometimes weaponizes shame. So we have this pressure to be a certain way. We have the consequence of being shamed by other people, feeling shame ourselves, which for humans is a really, really effective punishment, shame. So we end up with this pressure from society to keep up, to do it the way you've been told to do it, to not show it when you're hurt. So we feel this pressure from society. Oh, you can't keep up. Oh, you can't do it the way you've been told to do it. Oh, you're having a human response to being hurt. No, shame on you. Shame for doing that, even if it's not intentional from our loved ones. These are the kinds of messages that can really, really get into our nervous systems and start driving behavior in a way that is not sustainable. So, in this common pattern that we see, people are switching from the state in which they feel this urgent need to catch up, to compensate, to do as much as they can to try to get their life looking as if there is no chronic illness in their life. But of course, what happens is that this urgent adrenalized state takes up so much energy, it burns up so much energy that the inevitable consequence is utter collapse. For some people, it almost is that they feel that they have to do this part in order to earn this part. Like they have to drive themselves to the very brink in order to earn that collapse. Essentially driving the body so hard that the body then decides for you. The body then forces you. It takes the option out of your conscious mind and it decides for you, you will collapse now. So if we take a bit of a deeper look into what's happening here, we have quite an unfortunate setup that comes from just the design of our biology, okay? If we look at the design of our biology, we can see that humanity has made amazing progress with infectious diseases, with acute medicine, with pharmacology, amazing stuff that they can do. The early mortality, so early death due to infection, due to accidents, is way down compared with how it was back in the day. But interestingly, autoimmune conditions and on the mental health side of things, trauma-related conditions are steadily climbing. So it's clear that how we are responding to autoimmune conditions and trauma-related conditions is not good enough. We're not there yet in terms of really being able to master these things. So I think when it comes to chronic conditions, Western medicine can sometimes struggle with understanding multidisciplinary approaches, with being able to host the kind of holistic dream that Dr. Ziki was talking about. For both of our previous speakers, you can hear how much they value an interdisciplinary, holistic kind of approach to these things. And as of yet, Western medicine hasn't been able to accommodate that. I think there are beautiful signs of that happening. It definitely is. We're moving in that direction. But the consequence of this is that with Western medicine still coming to grips with these chronic conditions, the consequence for the people surviving those conditions is that they can feel that it's their fault, that they're not getting better, that they're not thriving, that they're not feeling in control again. It's no one's fault. But because you are already in such a sensitive, raw kind of a state, it's very, very easy then to start blaming the self. Okay. So in this kind of a cycle that we're talking about, fear, the experience of fear, the sensation of pain, and the biological function of inflammation, they were designed for short-term survival. Okay, all of those things were to help us escape lions. They were not designed for a chronic experience, that the kind of thing that has evolved in humanity since long ago. So you can imagine it like inflammation is supposed to act like a little EMT, okay, a little emergency worker. Inflammation is supposed to come as a little emergency worker, and the swelling from inflammation, which is just liquid, that is the creation of liquid to almost wall around the hurt part or the infected part to make it less likely that hurt part of the body is going to hurt the rest of the body. Okay, so excellent for getting swiped by a lion. Inflammation is going to help you there. The heat from inflammation is to try to ward off infection, because those little bugs usually thrive in the cold. So inflammation also brings a whole bunch of little white blood cells to heal, to mop up what must be thrown out, to make space for the repair. Okay, that's the little emergency technician workers that come. But after that, they're supposed to stop. Those little EMT workers are supposed to stop. They can't just keep going. They can't just keep going. The next order that should come from the system is to say, all right, EMTs, well done. Thank you. You guys take a break. Let's bring in the doctors, right? Let's bring in the nurses. Let's bring in the doctors. Let's move to the next phase of healing. And in autoimmune conditions, it's that part that goes wrong. That those little EMT technicians, it's almost like there's an accelerator, there's a brick on that accelerator. Those little EMT technicians are just going, and then a whole bunch of stuff goes wrong. Okay. So you start with increased autoimmunity, right? That's where we start with. The increased autoimmunity creates these symptoms of pain, fatigue, brain fog. I was so interested to hear Dr. Ziki talking about how many patients report that fatigue is the worst part. And that was definitely my experience as well. The pain, it sucks, but there's stuff that you can do for it. The fatigue, oh my hat, no. You get all of these symptoms, and they genuinely are unpleasant to go through, to say the least. These symptoms then create the thoughts, the feelings, the behaviors, which are completely understandable reactions to the symptoms. They fit. But unfortunately, those are exactly the things that feed stress, feed threat perception. So your threat perception becomes much more sensitive, and then all of this stuff contributes to increased autoimmunity. All of this stuff then feeds, this is fuel to the fire of increased autoimmunity, and around we go. Okay, so everybody, between the pain, the exhaustion, the loss of momentum as a productivity aid, with all of the fear, the anxiety, your system gets biologically overwhelmed. That's real. That's the car not having petrol. That's the car not having oil. That's the car not having water. It is going to seize up. That's just the way it works. This is not, if you feel that you can relate to, the either the boom bust cycle to this mind body loop, it's not your fault. It's not your fault. It's not something that you are doing wrong. It's just a function of the biological design, right? It is exactly like, what are realistic expectations of a washing machine? Okay. You want your washing machine to organize your diary? It's not going to work. You can expect that all you want. It's not going to work. So when we understand the biology, the system that we're working with, we can have more realistic expectations. Just like a computer, your computer can give you that little crash loop, right? Sometimes your computer is just like, I'm stuck. I'm stuck. Don't know where to go from here. And that's exactly the kind of thing that can happen in your system. Not your fault, just happens. So, I also just want to say at this point, the mind-body connection is a really, really hot topic at the moment. And I am I'm so glad that it is a hot topic. I'm so glad that we are talking about it. I don't think we've got the right words yet. I don't believe that we have a mind-body connection. The mind and the body are one thing. So there's no one point at which they connect like this. They are one system. I'll say more about that in a little bit. Everybody, very, very importantly, what we now know from the neuroscience is that healing happens in safety and healing happens in connection. Okay, that's when healing is possible. That's when healing is activated. That's when healing is optimized. When you feel safe and when you feel connected to the herd. Okay, so as Western medicine is still learning how to navigate this mind-body connection, as Western medicine is still learning how to talk about these things, I think it's very, very important that we start being more sensitive about how we talk about this. Because when we are so psychologically raw from living with chronic pain and illness, we can be extremely sensitive to any medical practitioner sounding as if they are dismissing us, criticizing us. And so, speaking of advocacy, we can also learn how to speak about it in a gentler, more loving, less critical way, so that we can start really integrating the sense of safety into all medical treatment. Okay. So let's just go a little bit deeper. Let's zoom in a little bit more before we zoom in, we zoom out again. So Dr. Ziki, she mentioned, she said that there are about 15 mechanisms by which the mental state impacts the physical state. Yeah, I haven't counted, but I think there's even more. There's at least 15. So one of the things that can happen is that we experience a central sensitization. This is usually diagnosed as part of fibromyalgia. But it can come with I mean, sometimes you feel that central sensitization when you have flu. It can come with any kind of, overwhelming illness. And what is happening here is if the mind is constantly perceiving threat, which happens on conscious and unconscious levels, the brain keeps the volume of your pain turned up to the max. Pain is a reporter. Pain is the signal that something's going wrong. So if your brain is saying we're under fire, your brain wants to hear the report of that pain, and it keeps the volume of the pain turned up to the max. Okay. We also then have the hypothalamic pituitary adrenal axis. And these are the little parts of your brain that give the orders for hormones. Okay, they are the manager that sits in your brain that's in charge of hormones. So if there is perceived threat in the brain, that little manager is going to be briefed. There's threat, there is danger, it's fight or flight time. That little manager is then going to give the order for lots and lots of cortisol. Send cortisol, send cortisol to the areas that hurt. Okay. Now, if there's too much threat, if the threat doesn't go away, the sense, the internal sense that there is something wrong, if that doesn't go away, then what happens is that the cells almost get drowned in cortisol. Cortisol usually helps inflammation. It's the balance to inflammation. But this time now, if too much cortisol is coming, the cells almost get drowned in cortisol, and the cortisol cannot balance out the little the cortisol cannot act as a little fire extinguisher. Yeah. And then what happens is that you get these little cytokines. So these were mentioned in the previous talks. These are the little guys, the first responders, yeah, who are the ones that keep providing the inflammation. They're the little guys who actually enact, they do the boots on the ground of the inflammation. Okay, so your cells are drowned in cortisol. Cells can't hear or cells can't allow the balancing effect of the cortisol to take place. And then those little boots on the ground just keep hammering away with inflammation. Okay. These little cytokines, little proteins that are supposed to help in the short term, but should not be there for the long term, they travel to the brain. They cross the blood-brain barrier. They get into your brain, and in your brain, they signal something different. They signal sickness behaviors. Okay, so sickness behaviors are all of the things that we do intuitively when something wrong is in the system. So sickness behaviors, again, should usually help us. It's wanting to go to bed, the urge to lie down, the urge to take it easy, sleeping a lot, not exercising, looking to comfort food, all of the kinds of behaviors, thoughts, feelings that we do when we are sick, those are cued by these little cytokines. So you've got a whole mess of cytokines creating havoc in the body, but they also travel to the brain and make you feel sick in your mind. They create brain fog, and they signal those sickness behaviors that are going to keep you stuck in the same place. Another mechanism by which by which your mental state affects chronic pain and illness is that okay, so this little guy right at the front of your brain here, it's the third eye identified by ancient Eastern philosophy. This is called the medial prefrontal cortex. And the prefrontal cortex is the last part of your brain to develop. It only completes its development in your mid-20s. This is the adulting part of the brain. This is the wisest, most measured, most mature part of the brain. Your best self is cued right here. Okay. Now, what we know from the neuroscience is that as your stress levels go up, this part of your brain is taken offline to conserve energy. It's like as your stress level goes up, as the threat level goes up, it's like your phone saying, cool, I'm going to go into low battery mode because that seems like a good thing to do when we're being threatened. So your stress goes up, your phone goes into low battery mode, and this adulting part of your brain taken offline. So you can think for yourself, does this feel like something that you can relate to, that as your stress levels go up, your decision-making ability goes out the window, your maturity goes out the window, your long-term goals go out the window, your deeply held values, they can really, really start feeling a little bit, less important than usual. That's literally because this part of the brain has been taken offline for conservation. And what's left in its place is emotion, memory, instinct, very things that really, really help again in the short term, but cannot help us with those long-term behaviors. Okay. So everybody in this loop that's going on, right? You are perceiving constant threat because you're scared of what's going on. You don't like what's going on. You're worried about how long this is going to go on for. You're worried about the effects on your life. That's the constant threat that we're experiencing. While we're doing all of this perceiving of threat, what's happening is that we're also not having any awareness of or feeling of security in being able to respond to that threat. If you have a tiny little threat that you know exactly how to respond to, how to take care of, your brain doesn't register it as something to panic about. Your brain just takes care of it. But now what's threatening you in your mind is something that you don't know how to just take care of. You don't know how to fight. You don't know how to run away from. You can't do those things, right? So your brain then keeps you in a state of fight or flight. It keeps you in a state of fight or flight to try and take care of this problem. That fight or flight state, that threat response state, is a huge devourer of energy. It takes up a whole lot of fuel. And it is also a completely different setting to what is required for healing, for repair, for synchronizing the system. Okay. Again, we're talking different settings on the washing machine. If you are going to put the washing machine setting onto dry, then your clothes are not going to be cleaned, right? If you want your clothes to be cleaned, put it on a different setting. So your fight or flight state is not the right setting for healing, for synchronization. Okay. In that fight or flight state, the brain wants the volume of the pain to be turned all the way up to the max. Now the problem is that it's stuck on max. Okay, and you are now experiencing that as physical, real pain. Okay, all right. If we look at, I just wanted to mention also the biologics that you guys might take. They work on these cytokines. They mop up these cytokines, and that's why so many people have such a quick experience of pain coming down, things improving, right? However, those cytokines are going to keep coming if your mind is the one that is initiating the whole cycle. Okay. Everybody, if all of this stuff is going over your head and it's information overload, that's completely understandable. If I can put this into a nutshell for you, I can say there are multiple points at which a vicious cycle can be triggered and fed. Okay, that's what it comes down to. There are these multiple access points for your mindset to either feed the cycle, trigger and feed the cycle, or to slow down and reverse the cycle. Okay, the problem here is that the design of our biology does have these flaws. The way out of these vicious cycles is at finding the same biological points at which the vicious cycle is triggered and fed. We can find points for which those vicious cycles can be slowed and broken. They are there, thank goodness. Okay, so everybody, if we start looking into the ripple effect, so let's zoom out again. We know that chronic pain and illness are very, very closely correlated in the research. We see over and over and over again, without fail, how physical illness and mental illness move together. They come up together, they come down together. Chronic pain and illness is correlated with high rates of depression, high rates of anxiety, PTSD. If you have underlying traumas that weren't treated, your chronic illness can be a major trigger to PTSD, and it can keep PTSD going. I don't advocate for, or let me not get into that. I'll just say that a new diagnosis of complex PTSD is also something that can happen. If you feel that as a person your PTSD never goes away, it's been with you for like your whole life, then you might be considered for a diagnosis of complex PTSD. OCD, non-suicidal self-harm, suicidal thoughts, perhaps sometimes with an intention to go through with it, sometimes with no intention to go through with it, but just thinking like, oh, I could just sleep forever, right? So all of these conditions are highly correlated with living with chronic pain and illness. And to me, that just makes the most sense. Doesn't it fit? Doesn't it add up? That when you have these physical things going on in your body, of course it's going to get into your brain. Of course it's going to get into your mind. How could it not? I think that we've been taught to view the body and the mind as being very, very as being two separate systems, right? The way that we've been taught about it is almost that your mind operates in one line, your body operates in another line, and every now and then they influence each other a little bit. No, that's not how it is. I think this is why I have such a problem with how we are talking about the mind-body connection, because they are one system. They are one thing. Let me ask you a little question. Where does your brain end? If I ask you the question, where does your brain end? So a lot of people are intuitively going to say, it's here, it sits in my head, right? It's in there. No, your brain extends its nerves all the way through your body, into your fingers, into your toes. Here's where your brain ends. Your toes, that's where your brain ends. Where does your brain start? Here, 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 here. It's all the same thing. It's not like brain matter nerves are composed of one type of tissue and your body is composed of another type of tissue. They are made of the same stuff. So when the ripple effects of psychological distress, loss of your social life, loss of your career, when these things happen, we shouldn't be surprised. We shouldn't be critical. We should accept these as a matter of scientific fact, worthy of as much attention as the physical. If we are feeling sick the whole time, and this experience creates thoughts that our survival strategies intend to help us. Okay, so I'll say that again. The survival strategies wired into your brain are always intended to help. There's actually no neuroscientific basis for self-sabotage. There's actually no neuroscientific basis for that. We don't see actual evidence for self-sabotage. That's not a thing. What we do see evidence for is survival strategies that worked in the short term, but now as they are used in the long term, they don't work anymore. So your beliefs about your worth are things that originally those beliefs would have been intended to help you to try to be accepted by the herd, to try to be accepted by the people around you. Another common pattern that we see is anger turned inward. When you're living with a chronic pain, with chronic illness, there isn't one specific thing that you can be angry with. You can't fight one thing to take care of this threat. You also can't run away from this thing. There's no running away from it. So one of the things that's left over is to take that anger and to turn it inward, to shoot it at yourself, because you happen to be the closest person around to express this anger towards, right? Our anger at the unfairness, at the injustice, at the powerlessness that we're experiencing can't be directed at anyone specific. So I'm right here. I can then shoot that anger at myself. Okay. The biological settings that come with threat detection for our survival responses, for our fight or flight state, these come with tendencies for shame, for blame, for despair. As herd animals, these thoughts about worth, these thoughts about being good enough, and all kinds of things like that, they are supposed to help us to be able to seek belonging. Except that now everything in your system is in overdrive. There's a brick on the accelerator. And so this shame, blame, and despair is just out of control. Okay. When we're thinking about our beliefs about worth, we're asking the question, how should society value individuals? How should society value individuals? Is it right? Is it right that people have to experience such trauma sometimes about their worth when they get sick, when any human being can get sick, right? If we're looking at that anger turned inwards, we can ask questions about how ableism, people assuming that everyone around them has the same physical ability as them, is it right for everyone to be assuming, well, I'm well, so you must be well, and if you're not well, that's your problem, right? We can internalize that ableist, and that ableist can really start getting very, very critical and harsh inside your system because it is trying to help you. It's just helping you in completely the wrong way, and that's where we want to change some things. The shame, the blame, the despair that we get stuck in are biological crash loops. This is your mind giving you the wrong message. It's trying to help you. It really is trying to help you, but it is giving the wrong message. And it's that message that is spiking the stress levels so high that we then get caught in biological crash loops. Okay. So everybody, again, if all of this biological stuff is, information overload on your fatigued system, that's completely understandable. You can always come back to this information and repeat it as much as you need so that it can absorb into the system. But again, I can summarize it as your brain cannot distinguish between an external threat and an internal threat. So your brain treats how you speak with yourself, how you think about yourself. It treats that as the same kind of threat as a lion running at you. Okay? If you're trying to water a plant with polluted water, that plant is not going to thrive. It's not possible. So the way that you speak with yourself and think about yourself can be like trying to water yourself with polluted water. And again, it's not your fault. It's not your fault that watering with polluted water is happening. It's a function of the design of the system. We, the healthcare professionals, the patients, the advocates, everybody involved cannot be at war with the body. If we are perceiving ourselves as the threat, that's going to keep the whole cycle going. Thoughts like being a burden, being unworthy, being stupid, being selfish, these are quite literally poison. The biological effect of those thoughts on the rest of the system is poison. So what do we have to do? We have to reprogram the thoughts, the feelings, the behaviors, everything that we have conscious control over. We can affect those things to unstick the whole system. And it's easier than those stuck setting thoughts would have you believe. Okay? Your depressive thoughts, your blaming, your shaming, your despairing thoughts, they might not like what I'm saying here. That's understandable because you might have experienced, seeking mental health care and it doesn't work, or seeking mental health care and you don't like it. It's weird. Okay. But with all of the development that we've had in the field, we now have so many options for your mental health care that you can really, if you claim it for yourself, as was being discussed, you can really be in control of how your mental health care goes. Okay, so everybody, at this stage, I just want to take a pause. Okay, so I know if you're living with chronic pain, chronic illness, you might really need a wiggle. You might really need a bit of a stand up or a shift or any kind of thing that you want. Please feel free. I encourage you to do that. But I also just want to demonstrate a few of the techniques that we might want to use. Okay, so if we want to stop being at war with the body and start working in relationship with it, we have to slow down, we have to listen up, and we have to be willing to experiment to find the tools that work for each of us. Everyone listening to this is far too complex for any mental health care practitioner to know for sure what will work. Okay, if a mental health care practitioner is selling you a for sure treatment, I would slow down and check if they're the right person for you. There are no absolutes in psychology, but we can take an experimental mindset and try out a whole bunch of stuff. So let's take a pause now if you are feeling up to it. And I want to invite you to try something out with me and just see how your body responds. So everybody just get a little bit comfortable, just adjust your seating, lie down if you want to, stand up if you want to, do what you need to make your body feel comfortable enough. And now I want to invite you to just take your attention inside your own system. Okay, and almost start with trying to feel out what the weather is like inside your system. Just gently, with curiosity, with observation, just feel into what the weather's like. Is it a big, stormy, hectic hurricane kind of a day inside? Is it one of those like heavy, overcast days? Is it raining? Is it winding? Is it sunny inside? Just feel into that a little bit. And I want you at this stage to just scale that weather a little bit. Inside yourself at the moment, just give yourself a number from 1 to 10, or a percentage. Let's go with a percentage. So 0% would be the absolute worst you have ever felt in your entire life. That was your absolute pits. 100% being your best sunshine summer day. And just kind of intuitively, it doesn't have to be too logical, it doesn't have to be too precise, but just intuitively see where you are in that scale today, 0 to 100%. Okay, all right. So now keeping your attention inside, let's just start by slowing the breath. Just start with slowing it down. And when you've been able to slow it down a little bit, see if you can soften it. So we don't want forcing in the breath. We don't want tension in the breath. We want it to be a nice, slick, easy breathing that's happening. Now see if you can deepen the breath. Let it drop lower in your lungs. We want it ideally to drop into the belly. We don't want you to be high at breathing up here at the top of your lungs, at the top of your chest. We actually want our breath to be happening in the bottom section of our lungs, the section that sits in your belly and in your middle back. That's where you have the most volume to your lungs. And that's where your lungs can actually start telling your muscles, it's okay. We don't have to be so tense. Okay, so we have softened the breath. We've slowed it down. We've dropped it into the stomach. And when the pain comes, when it comes, not if it comes, but try to meet it with breath, just for this experiment. I am going to count for us a little bit to try a technique called triangle breathing, in which we're going to breathe in. We are going to hold the breath at the top, and then we're going to breathe out for twice as long as we breathed in, okay? So we are going to try breathing in for a count of 5, holding for a count of 5, and then breathing out. Let's go 4, 4, 8. Breathing out for a count of 8. Just do your best. If you fall off the counting, that's absolutely fine. It does take a little bit of practice. So just gently see how you can do this. So let's go. Breathe in through the nose into the belly, like blowing up a balloon. Hold. And now breathe out slowly. Beautiful. In again. Hold. Out slowly. In. Hold. Out slow. In. Hold. Out slow. All the way out. Really letting the last bits of breath squeeze out. In. Hold. Out. Last one, make it count. In. Hold. And out slow. And release the breathing exercise. And now just take a moment and check your percentage. Do you feel 5% better? 3%? 10%? No change? Valid answer. You don't like that one? Valid answer. Just check it out for yourself. Okay. Let's keep going. Next experiment. This time we are going to experiment with something called a somatic resource. And so this time I want you to gently close your eyes If you feel comfortable, if you don't feel comfortable closing your eyes, you can just let them rest on a low spot in front of you. And bring your attention to your heart, the actual organ that's sitting in your chest. And I want you to really imagine it as a 3D object. It's this chunky muscle sitting in the middle of your system. It extends out into the front of your chest. It takes up space into the sides of your ribs. It takes up space into your back. And on your next inhale, you're going to imagine lifting the heart. Breathe in. Lift the heart. For me, it feels about 1 centimeter, 2 centimeters of my muscles actually lifting the organ within my chest. And as you breathe out, release. Let's go again. Breathe in. Lift the heart. And breathe out. Gently, gently, gently. Listen to yourself when your system asks you to not move that muscle or move that one. Listen to yourself. Breathe in. Lift the heart. This time, as you lift the heart, let the chin float up with it so that the chin is now parallel to the floor. And release it again. One more time. Breathe in. Lift the heart. Let the chin float up. Let the face float up. As if you are enjoying some sunshine on your face. Last time, breathe in. Lift the heart. The chin float up. Let the face float up. Imagine that sunshine on your face. And release it again. Just take a few seconds. And then scale again. 5% better, 3%, 10% better, no change. Don't like it. Just collect data for yourself. Okay, next experiment. So this time we're going to breathe in and then hum all the way out. Like that. Okay, and so what you want to try to do is you want to try to drop the hum into the back of your throat and low into your throat. You really want to see if you can let the jaw and the muscles in the mouth be slack, because what we're really looking for is a feeling of vibration that comes from your hum into the sinuses, the jaw, the throat, and the top of the chest. Okay, that's the ideal. Does take some practice as well. So just focus on a nice low hum. Okay, so let's go. Breathe in. And hum all the way out. You can hear there, I'm trying to get the hum all the way to the end of the breath, and I'm trying to get a nice vibration going. Let's try again. Breathe in. Hum out. On your next in-breath, hum out. One more time. In. All the way out. Take a few seconds again. Scale it again. Do you like that one? Is it feeling like there was a different one that was more effective? 5% better? 7% better? And our last one, also just to finish this mind-body practice. Take a lovely deep breath in, a nice full breath into your belly. Sigh it out. Let it drop. Let it drop out of you. And if you get the audible sigh, you're giving another massage. I'll explain about that. Breathe in. Sigh it all out. Don't go too fast. Breathe in again. Sigh it all out. And you can scale that to 5% better, 2% better, no change, you don't like it. Okay, and if your eyes have been closed, just flutter them open. Just to measure the light back into the eyes. We don't want to wrench the eyes back into the light. But now just have a think about that inside weather again. And just see, what's the weather inside? Could you create a break in the clouds? Could you perhaps warm the temperature? Is there anything that has shifted from the inside weather? And everybody, it's most likely that your pain will not have come down from these regulation exercises, but your stress levels might have come down. So, learning about conscious pain management can be about a patient with the pain levels. Being patient with your pain levels and focusing on decreasing the distress that comes with pain, the panic, the despair, the tension. Those are the things that we have conscious control over. And when we can bring those down, you are activating a state that contributes to getting unstuck rather than a state that keeps the vicious cycles in place. Okay? So if I now bring us back to reclaiming your narrative, all right? The reality, everybody, is that there are no silver bullets when it comes to chronic illness and chronic pain. I would be very skeptical of anyone telling you this is the thing, it's going to work. People are way too complex for that. The reality is that an open and experimental mindset is the quickest way of finding what works for you. I know it's so frustrating having to go back and try this and try that. But if you put yourself into an experimental mindset, that can also be less stressful, less frustrating. Our goal is not necessarily to bring down the pain or the fatigue directly. Those are not necessarily pathways that we have with our conscious mind, but we can bring down our stress levels with our conscious intentions. And that is what is going to indirectly bring down the stress, bring down the pain, bring down the fatigue. Your options for psychotherapy or counseling, these might be specifically for underlying traumas, for underlying stress management that is adding fuel to this whole fire. Okay. There is a new form of psychotherapy called pain reprocessing therapy. And this is a specific and targeted kind of cognitive behavioral therapy that is based on the neuroscience. It's not very available in South Africa, but there are practitioners who do it. So if you want to, do the research, find someone who practices that, you can. But you can also go into psychotherapy or counseling for nervous system regulation, learning how to break the vicious cycles through your relationship with yourself, through healing and repairing the relationship with yourself so that you could bring your stress levels down and motivate yourself to do the health-seeking behaviors, motivate yourself to get through the exercise, to get through all of the eating of broccoli, to get through the appointments and, all of the health admin that comes from living with chronic illness. If your nervous system is regulated, all of those things feel much, much more possible. And also, I'm so happy to see how this organization encourages movement. You know, I think there are forms of movement that really work for chronic pain and illness, and forms of movement that don't. So if you do your research and find the ones that are designed for this, ooh, they can make a big, beautiful difference. And then the recommendation from the psychological side of things is for graded exposure. Literally, so I do this form of dancing called Nia dancing, and it's a non-impact kind of dancing. And you know, it builds muscles, it does all of the things, but what's great about this form of dancing is that it is really, really gradable. You can literally do one movement of just a bit of 1 minute of just a bit of this is better, so much better than nothing. So if you're not up to a whole class, you do what you can do on that day. And that's the type of movement that is going to work for people with chronic pain and illness. And that graded exposure is literally, if you can handle a minute today, do it. If you can handle a minute and 30 seconds tomorrow, start there. Sometimes we have to pry open millimeter by millimeter a gap for us to get moving into. You can also mindfulness is, yeah, it's been a hot topic. I don't think that it should stop being a hot topic. I think as much as we talk about going to the gym for our physical body, mindfulness is gym for the brain. So if we do gym for the body, we should be doing gym for the brain. That just makes a lot of sense to me. But very importantly, there isn't just one way to learn and to practice mindfulness. So if you're into it, go for it, please. It's so, so, so good for synchronizing the system, for breaking that stress, the vicious cycles of stress. But if you have sort of tried mindfulness and you felt like it wasn't for you, it might have just been that way of practicing mindfulness. There are different ways, and you can really find the way of practicing mindfulness that suits your style, your personality, and the way that you do life. There are options. Everybody, there are options, and the toughest part is that you have to create your own chronic pain and illness regimen. You have to create one for yourself. You have to build it for yourself. But if you can get into that experimental mindset, then you can build that for yourself. There are so many options these days. You want to have as many of these things as possible. We want to approach the regulation of your system from as many angles as possible. Movement plus counseling or psychotherapy, plus trauma release exercises, plus sleep therapy, you know, whatever it is, as many as possible. If we go back to the scaling questions that I was asking you while we were experimenting with some regulation techniques, I was asking you, does it feel 5% better? And what we're really looking for is, there is no silver bullet. There's nothing that can make you just feel 80% better. It doesn't exist. But what's very, very possible is, if you want to feel 20% better, then you need to do 4 of the things that make you feel 5% better. If you want to feel 50% better, you have to do 10 of the things that make you feel 5% better, right? You have to build it for yourself. I want to encourage you to fight for yourself, to claim your space, and to really go after all of the apps that are available, the YouTube videos. There is so much that you can use to understand what's happening and what's your way out. And I really believe that your relationship with yourself here is make or break. We know that self-critical thoughts are poison, but self-constructive thoughts are also what you need to experiment, to persevere, to insist on finding joy and peace and play again. We can't be at war with the body. That's not going to work. So let's think about this. Let's just think about how you can reclaim your narrative. If chronic pain and illness are realities rising globally all across the human race, should society continue to ignore and neglect and punish the people who are trying to survive them? Don't know what you think about the complexities and the nuances and whatever, but to me, it doesn't make sense to do that. That's not the way that our society should be organized. If chronic pain and illness survivors know something about survival that others don't, if you, as a chronic pain and illness survivor, know something about resilience that other people don't, should these survivors be ignored and neglected, or should they be consulted? I feel like when you guys are doing so much more with so much less, you should be consulted about your resilience, not criticized for not doing well enough. If chronic pain and illness survivors are prone to shame, which makes them sicker, should they be supported or further shamed? Again, this stuff for me feels like a no-brainer. How should we teach people to treat us if it is the case that people who don't have chronic pain and chronic illness, if they don't have a frame of reference, they can't imagine this, then how can we teach people? How can we give them information to help them to speak to us more gently, to make their expectations of us more realistic? How should we treat ourselves? Does it make sense to be treating yourself with aggression, with shaming, because you have something that's not within your control? I don't think so. We are thinking here, when I'm asking you to reclaim your narrative, I'm thinking about restoring your body, changing the story that you tell about your body, and moving from my body is a traitor that sabotages me to my body is my oldest friend, navigating a really, really difficult world. This is what it can sound like when we're talking to ourselves in negative ways. The way that we talk to ourselves matters. And so removing the fuel to the fire of the way that we talk to ourselves is a really, really good way of just starting to stop adding fuel to the fire. We want a mindset, a relationship between you and your body that is optimized, intentionally designed for this problem, intentionally upgraded, evolved, equipped to be able to handle this problem in front of you. I want to ask you again, in the story that you tell yourself, are you the victim? Are you the damsel in distress? Are you the villain? Are you the sidekick? Do you want that story for yourself? Is that the story that you want? What about the ending to the story? Is that what you want? And if it's not, get in there, change it, claim it, it's yours. If you need some help with that as well, go get help and support for that. Humans are herd animals, and we are wired to heal in connection and safety. So everybody, I just want to leave you with a quote, something that has been incredibly important in my own personal experience with chronic pain, with chronic illness for my clients. And you know, this is the kind of idea that can really irritate and can really yeah, it can feel frustrating to people who are so raw from the experience of living with chronic pain and illness. But just slow yourself down a little and just observe with curiosity what this idea provokes in your system, and whether you agree or whether it's worth considering before you disagree. Pain is inevitable, part of the human condition. Suffering in response to pain is optional. Your response, your experience of the pain, that's where you have control. That's where it's never going to be a a light switch moment. It's never going to be quick. And unfortunately, it's not that easy. But there are options for removing the suffering from your condition. Here's a contact card for you guys. If you feel like I might be the person to help you with your mental health care needs, please do reach out to me. We can have a chat about whether I'm the right person for you or not. I do individual and couple sessions, and for the moment, all of my sessions are online during office hours and in the evenings. Okay, that's me, everybody. I'd love to hear from you now.
Are there any questions for Mia, guys?
I'm just looking at the comments. I see from Dane, you feel like you can respond to that. Dane, I'm just looking at your question here. Your understanding is that there are three main areas of the brain: reptilian, limbic system, and prefrontal cortex. So are we getting stuck in functioning without our prefrontal cortex at its optimal level, that it comes and goes? Is that correct? Yes. So this model of the brain, the reptilian, the limbic system, and the reptilian, the mammalian, and the prefrontal. So that's a model of the brain that is actually a little outdated, but we still use it because it's really helpful to just understand what we're working with. It's a really helpful, I suppose, summary. So where this model has been updated these days is just in its complexity, in the amount of detail that we see in that model. But you're correct, that is exactly what's happening. As the stress levels go up, the limbic system and the reptilian brain, which are they're the quickest workers, they are given all of the energy so that they can prioritize survival. And your prefrontal cortex is taken offline to conserve energy. So what that results in is, if you're spending too much time without the involvement of your prefrontal cortex, what's happening is that your emotions, your instincts, your impulses and reactions, those are the guys who are now leading the show. They're running the show, they are calling the shots, and they might be really, really good at survival, but they're not good at thriving. They're not good at long-term goals. They're not at value. They're not good at value-driven living. So you're correct there. Ways of practicing mindfulness. So yeah, everybody, I mean, there's multiple different ways. For example, one of my favorite ways of practicing mindfulness is mindful eating. So that was actually the way that I was introduced to mindfulness for the first time. And mindful eating is cool because it really, I remember the first time someone did a mindfulness exercise with me, and we used a nachi for mindful eating. That was the best nachi I've ever eaten in my entire life. So delicious, so juicy. Just now that I was focusing on it, I was like, wow, this is an amazing nachi. So mindful eating can really help you to experience your food differently. It can really, really help if you have some kind of eating disorder. Mindful eating is a really, really good way to go. And it also means that you're getting the benefits of mindfulness with the simplicity of putting your attention on food. There's mindful walking. You can do your dishes mindfully. So I used to do a daily mindfulness practice, trying for 20 minutes to do the thing. But now what I do, and sometimes I recommend this to my clients, is to take little bite-size hoppies of mindfulness the whole day long. So you just stop and really absorb it when you feel the sunshine on your skin. If you see, if you're in Joburg and it's time for the jacarandas, then just take a few minutes to really look at them. Let that color come into your system and give you something. So yeah, multiple ways of practicing mindfulness. And again, you can experiment and see what works for you, what vibes with you. I see a comment from Anya. Am I the only one struggling with the various forms of grief that comes with this illness? Your old self, what could have been relationships, etc. Oh, Anya, you are not alone. I'm so sure that most people living with chronic pain and illness can relate to that feeling of grief. We actually have a term for it, which is ambiguous grief. And what that means is that a simple form of grief might be like your dear grandmother is 97. She has been around the world in 80 days. She's lived a wonderful life, and now it's time for her to go. And there's a beautiful togetherness, sense of community, sense of ritual in honoring her and saying goodbye to her. There's a burial. There is finality to that loss. And so it can be simpler to grieve because it makes sense, because it's expected, because it fits with this whole life story. When you lose a future that you thought you had, that is like losing someone, except now you can't grieve it in the way that humans usually grieve things. If you lose a version of yourself, how you knew your productivity, that is a very real grieving process, and it is complicated by the fact that it's not final, it's ambiguous, it's shades of gray. And so that's definitely the type of thing that you can go to psychotherapy or for counseling for, to just be able to process some of that strange, difficult to understand grief. And then I just see, yeah, some more agreeing and disagreeing. Dane, I see you say I'm starting to claim the new narrative for myself with self-love and acceptance for having 4 chronic illnesses. Holy smokes. Problem is my friends and family still choose to shame and judge me. And oh my goodness, again, what a common experience that I see from my clients is that you're doing so much work to love yourself, accept yourself, take care of yourself in this situation, and other people are not giving the same investment to what you're doing. That is such a difficult part of it, because that's really what can get into your isolation. Those things can feed depression, anxiety, trauma. That is delicious food for depression, anxiety, trauma. And I think it really comes down to learning how to put up those mental boundaries to say, you haven't earned your judgment of my illness. You haven't earned it. You don't know what you're talking about. So unless you are a doctor who knows my case backwards and forwards, and unless I've asked, your judgment belongs to you. That's yours. It's not mine. And when friends and family go over the line of actually full on shaming you, to be able to have those boundaries of, I do not need this. I'm trying to focus on health. This is not healthy. So I'm going to put my focus on health. If you want to put your focus there, you got to do that. I'm saying this in quite a flippant way. I know that these kinds of boundary settings, navigating your relationships, it's big, it's complex, and it definitely deserves to be understood and to understand what tools and techniques can help you to feel that your relationships are meaningful, supportive, that you're benefiting from them. Any last questions? Or Tanya, I don't know if you want to close now.
Well, let's just see, is there anyone else that wants to ask Mia anything while we've got her here? Mia, I think your talk was incredible. It was so informative, and I know that I've learned so much today, and I think everybody else has as well.
Glad to hear it.
I think we all feel validated by
Mm.
what you said today. The whole mind-body connection, it's what, like you say, people see it as two separate things, but it really isn't. It's all integrated. And I think the boundaries that you were talking about now, I think boundaries are key for us to protect our
Mm.
energy, and to just, whether it's at work or at home with friends or family, I think there's a lot of boundaries we need to set, which is tricky because we might not have had those before. But I think that all the information you shared was amazing, and I'm so grateful that you joined us today. And just thank you very, very much, Mia.
You're so welcome. Thank you so much for having me. I'm so glad to hear that it felt validating. Yeah, definitely boundaries. I can easily spend another 90 minutes on boundaries.
Yeah.
If you guys would like to have me back, we can go there. Absolutely.
Mm, that's super. No, I've got your details now, so you can be sure you're going to hear from me again. Is there anybody else that wants to say something before Mia goes?
Thank you.
Well, I think maybe.
Yeah.
There we go.
You're very, very
There's,
welcome.
I see there's some hearts floating around for you as well, Mia. So yeah, lots of nodding happening.
Yeah, back at you guys. We need each other. We need each other.
Yes, definitely, definitely. Thank you so, so much, Mia. Hope you enjoy the rest of your weekend. Um, I want to ask everybody who was here today, did you enjoy this? Did you learn something? What was your favorite part? Give us a little bit of feedback before we say goodbye.
It was an awesome morning. We learned a lot from Dr. Ziki right through to Mia, and Mia's her as being the last speaker was a perfect closing and putting everything together. So thank you for organizing this. This was great.
Thanks so much, Charlene. We appreciate your feedback. Anybody else? If you've
Yes,
got,
Tanya.
yeah,
I just want to say thank you to you for organizing and being the main organizer and getting the speakers together. It's difficult. I was helping last year and it's very, very challenging. It's a stressful day. I'm sure you're exhausted by now. So
yes,
thank you for your input because as Charlene said, each talk was amazing. I caught bits of the second talk, so I must go back and watch it. But I understand that the talks will be posted on YouTube. Is that correct?
yes. No, we will definitely do that. We have been recording, so it's always nice to be able to go back and just do a little bit of a refresher. Um, but if anybody has any follow-up questions, that come to mind afterwards, please feel free to pop me a message. I'm sure you've seen me all over WhatsApp and Facebook. Um, I'll quickly pop my number in the chat as well, so that if you want to send a WhatsApp with any follow-up information that you may require, please feel free to do so. And I think from today, I think we've also identified some topics for the future that we can have a look at. I think it seems like everybody has now said what they needed to say. I think we're all tired. It's lunchtime. We want to go back to our long weekends, and especially after all the breathing with Mia, I think I'm ready to go take a nap. So thank you very much for being here. We really appreciate it. World AS Day only works when you show up. So thank you very, very much for being here, for taking the time out of your weekend. And I hope you learned something, that you will have a wonderful weekend further, and that we'll see you at the next, on the couch, probably, hopefully.
Thank you.
Thank you, team. Have a lovely weekend and happy World AS Day.
Thanks, Miranda.
Bye, guys.
Bye.
Well done.